Soruyor.
Çekil kalemi. Onlar da var.
İmajı.
Bunu da aç. Bir de şey abi. Yasemin su. Şimdi heybe vereceğiz abi. Hasan, eltanın içine heybe diye bir şey.
Şunu vereceğim. Dur Fatma. Oh, this is so good. And I yeah, this for some.
Tamam, in aşağıya. Şu mikrofonu al.
So we'll bring this session to a close now. We had excellent sessions about low-risk trauma decision-making, then a hemodynamically shocked patient using TEG-guided MHP protocol, and then 2 cases with unfortunate outcomes following major trauma. And finally,
Atuder ve Vacem Başkanı Sayın Profesör Doktor Başar Cander. Bir diğer konuşmacımız ise Altınbaş Üniversitesi Klinik Farmakoloji Bilim Dalı'ndan Sayın Profesör Doktor Barkın Berk. Sempozyumumuzun ilk konuşmasını yapmak üzere değerli dernek başkanımız Sayın Başar Cander'i buraya davet ediyorum. Buyurun hocam.
Evet arkadaşlar, hepiniz hoş geldiniz. Gerçekten görüyorsunuz 3. gün ve hemen her salonda bir aktivasyon var. Salonlar yetmiyor. Özellikle burada arkadaşlarımız çok ciddi bir koşturma içindeler. Ama Dünya Kongresi olmasının böyle bir heyecanı var, böyle bir şey var. Ya burada yabancı konuklarımız var. Onlara biz Türkçe yapacağız anlatımı. Kulaklık getirebilir misiniz yabancı konuklarımıza? For Hasan El Tani and other maybe Sagar and okay. No, wait please. Okay. Biz başlayalım. Şimdi arkadaşlar, tabii ki acil servislerde en çok karşılaştığımız semptomun başında ağrı geliyor. Ama düşünün, mesela birinin bacağı ağrıyor veya omuzu ağrıyor veya boynu ağrıyor şikayetiyle geldiğinde ilk hissettiğimiz duygu nedir arkadaşlar? Aslında bir rahatlama hissediyoruz. Neden rahatlama hissediyoruz? Çünkü şikayetinin çok ağır bir şikayet olamayacağını, yani bir ekstremite, kas, iskelet sistemi hastalığı olduğunu düşünüyoruz. Dolayısıyla hani bir kırmızı alan hastası değil de bir sarı alan, yeşil alan hastası olduğunu, reçeteyle tedavi edebileceğimizi veya kısa şekilde tedavi edebileceğimizi düşünüyoruz. Ama burada biraz yanılıyoruz. Neden yanılıyoruz? Evet, ağrı hayatı tehdit eden birçok şeyde ağrıyla geliyor. Ama diyelim kas iskelet sistemi ağrıları bizim hayatımızı en çok etkileyen olaylardan biri. Mesela biz workshop yaptık İstanbul'da. Workshop yapınca bir hocamız workshop yaptığımız otel mesafesiyle hastane arası 500 metreyi geçmiyor. Sayın Boy vardı burada. Otele yürüyüp geleceklerini planlamıştık. Bir türlü gelemediler. Sonra sorduk nerede arkadaşlar diye. Onlar da telefon açtılar, dediler ki ayağını incitmiş, yürüyemiyor. Bu yüzden gelemiyor. Biz bir arabayla aldık. Şimdi şöyle düşünün, biz buraya aylarca, yıllarca hazırlandığımızı söylüyoruz. Ama bir ağrı semptomu, bir boyun ağrısı, bir kas ağrısı bizim bütün aktivasyonumuzu burada ne yapabilir? Geriye düşünebilir. Yani bunu hayatta da gördüğünüz zaman aslında basite alıyoruz ama yaşayınca şunu anlıyoruz. Hepimiz yaşadık, yaşıyoruz. Bunun aslında hayatımızı ne kadar etkilediğini görüyoruz. Mesela hepimizin deneyimi olmuştur. Yaşamadan anlamıyorsun diyorsun ya. Ya mesela her gün çorap giyiyoruz değil mi? Çok basit. Herkes çorap giyiyor. Sırtı tutulan biri, sırtı ağrıyan biri nasıl çorap giyiyor? Ben birkaç defa denedim, neredeyse düşüyordum. Mümkün değil yani. Yardımsız çorap giymeniz mümkün olmuyor. Dahası şu iki skapula arasında ağrısı olan oldu mu? İsa'nın varmış iki skapula arasında. Uzanmaya çalışıyorsun, birden saplanıyor. Uykun geliyor ama uzanamıyorsun. Uyuyacaksın, şansın yok. Yine çok önemli bir şey var. Boyun. Hele böyle uzun boyunlu olanlar, şu 8 omur. Boyun tutulması. Ya sağa dönemiyorsun. Sola dönemiyorsun. Yani hayatımızı o kadar etkiliyor ki bu ağrı. Haftalar içinde bakıyorsun, ya bir şey yok ya, işte kas ağrısı geçer, şunları kullan. Ama onun hayatında ne kadar yeri var o ağrının. O yüzden bizim bu tedaviye çok dikkat etmemiz gerekiyor arkadaşlar. Şimdi kas iskelet sisteminde hepimizin bildiği şeyler var. İşte kemikler, eklemler, kaslar, pasif elemanlar ve aktif elemanlar olarak söyleyebiliriz. En genel belirtiler ne? Ağrı, işte sabah tutukluğu, hareket kısıtlılığı, kas kitlesinde azalma, krepitasyon, hassasiyet, halsizlik vesaire, bunlar semptom olarak karşımıza çıkıyor. Tabii bunlar bizim hayatımızı, sosyal hayatımızı engellemek yönünde çok etki ettiğini az önce belirttik. Ama bunun dışında da şuraya görüyorsunuz arkadaşlar, herhalde şuradan göstermem mümkün, pardon. Geriye alabilir miyiz? İleriye alalım. Bir daha ileri. Evet, şurada görüyorsunuz. Şunu nereden? Evet, acile başvurma. Ölümcül olmayan hastalık yükü içinde. Yani psikiyatrik hastalıktan sonra sondan 3. olarak görüyoruz burada. En sık görülen 10 hastalık istatistiklere göre bel bölgesi kas iskelet sistemi problemleri 1. sırada. Yani bize en çok başvuran hasta grubunda ilk sırada yer alıyor. Ama 3'e, 5'e de dikkat edin, 8'e dikkat edin. Bütün bunlar hep ne? Hep ağrı semptomu. Yani sonuç olarak şuraya geliyoruz. Ağrıyı dindirmek çok önemli bir sanat. Bunu kabul etmemiz lazım ve bu ağrıyı kesmenin de önemli bir iş olduğunu anlarsınız. Ben modern tıp konusunda gerçekten şeyler olabilir. Bakın kafamızda bazen soru işaretleri oluyor modern tıp konusunda. Acabalar oluşabiliyor. Ama modern tıbbın doğruluğunu kendi vücudumda en çok hissettiğim yer ağrı kesiciler. Eğer etkili bir ağrı kesici. Mesela bir diş ağrısı çekiyorsunuz. Hayatınız kararıyor. Hiçbir şey yapamıyorsunuz. Şiddetli ağrı için diyoruz. Ve bir ağrı kesici eğer sizin diş ağrısınızı kesiyorsa veya renal koliyi düşünün veya işte bahsettiğim sırt bel tutulması. Ağrı kesici alıyorsun ve birdenbire bir konfor hissediyorsun. Bir mutluluk oluşuyor. Dolayısıyla arkadaşlar ağrı kesmenin bir doktorun en önemli görevlerinden biri olduğunu unutmamamız gerekiyor. Bu yüzden de tabii ki biz ağrı kesicileri çok fazla kullanmak, çok fazla yazmak durumdayız. Bunun için de mutlaka ağrı kesicileri çok iyi tanımamız gerekiyor. En sık kullandığımız ilaçlar olduğu için. Tabii burada bir ağrı var, bir de spazm var. Bunlar birbirini tetikliyor. Bel boyun ağrıları gibi spinal bozukluklarda bir de spazm ekleniyor. Spazm da ağrıyı arttıran bir şey. Yani ağrı oluştuğu üzerine bir de spazm, bunlar bir kısır döngü oluşturmuş hale geliyorlar. Yani sırt ve omuzlar ben anlattım. Bunların hepsini ben yaşadım. Tabii siz de yaşayacaksınız. Yani bu kaçınılmaz bir şey. Yıllar ilerledikçe daha fazla yaşıyor insan ama yani gençken de yine yaşadığımız iskelet ağrıları mutlaka peşimizi bırakmıyorlar. Bunları düşme çarpmayı söylemiyor. Onlar zaten kaçınılmaz ama gerek postürden gerek de yaşla ilgili mutlaka bu ağrılar, bu spazmlar karşımıza çıkıyor. Bunun değişik nedenleri olabilir. Mineral eksikliği olabilir, dehidratasyon olabilir, yetersiz kan akışı. Bunu tersten bakmanız lazım. Yani kas spazmı deyip geçmeyin. Evet kas spazmı vardır ama belki bunun altında bir yetersiz kan akışı vardır. Yani o zaman ne yapmamız lazım? Ona bakmamız lazım. Dehidratasyon var mı? Ona bakmamız lazım. Yani bir hasta size kas ağrısıyla geliyorsa tamam demememiz lazım. Acaba bu kas ağrısı neden var konusunu mutlaka düşünmemiz gerekiyor. Kasların aşırı kullanımı da kas spazmı nedeni oluyor. Bunu hepimiz yaşamış olabiliriz. En son dünkü maçtaydı değil mi? Ben maçta bu neydi? Fred miydi? Fred değil mi? Fred'in kaslarında bir şey oldu. Kaçıncı dakikada çıktı? Biz bir taraftan kongre takip ederken bir taraftan da bunları görüyoruz yani. 45. dakikada Fred'i çıkarttılar değil mi? Benden başka Fenerbahçeli yok yani. Peki. İlaçlar sebep olabiliyor spazmına. Ani keskin ağrı varsa, cilt altında sert bir kas dokusu hissi varsa, kas seyirmesi varsa biz bunlarda kas spazmını görüyoruz. Şimdi gerçek bir spazmda kasları uyaran sinirlerin aşırı aktivitesinden kaynaklanmıştır. Tek bir kası ya da bir grup kasın tamamını kapsayabilir. Kas yorgunluğu, yaralanma, kasların aşırı kullanımı gerçek kramplara neden olabiliyor. Böyle ani bir ağrı ve sizi hareket ettirmiyor. Vücudun su kaybetmesi, sodyum eksikliği gerçek krampların diğer nedeni. Yani acilde çok fazla karşılaşıyoruz tabii sodyum eksikliğine, hiponatremiye ve bu da bizim için önemli. Tetani tipi spazmlar değişik hastalıklarda özellikle kalsiyum önemli, potasyum önemli bu durumlarda. El ve el bileklerinde kas spazmları daha çok biliyorsunuz düşük kalsiyum seviyelerine bağlı. Distonik spazmlar olabiliyor. Bu da daha çok aşırı kas kullananlarda, amaçladığı hareketin ters yönünde kasları kullanan kişilerde görülür. Yine önemli bir şey, belki bizim için önceden önemliydi. Şu anda pek yok ama yazar spazmı. Şimdi klavyeye bağlı oluyor mu spazm olan var mı klavyeye bağlı? Klavyeye bağlı. Kimsede spazm yok mu? Görebilir miyiz? Yok. Bizimkiler ama mesaj bu. Çok mesaj yazanlar, Instagram yazanlar, Facebook. Bir bakıyorsun şöyle kasılmış geliyor hastaneye şöyle. Tamam Instagram işi bu. Öyle düşünün yani. Bel kas spazmı bu da kötü. En sonunda bir şey yapalım, anket yapalım. Hangisi daha kötü diye. Gerçekten bel kas. Böyle duruyorsun. Bunları da yaşayınca daha iyi anlıyorsun. Hastaları da daha iyi anlıyorsun. Kas güçlü değilse vesaire bunlar oluyor. Evet bunlar hayatı tehdit etmeyebilir ama birçok insan hayatını tehdit ediyor. Neden? Ya adama hazırlanıyorsun. Mesela şu anda düşünün biz bu kadar çalışmadan adam Hindistan'dan geldi, Japonya'dan geldi. Ondan sonra diyelim ki kası tutuldu, beli tutuldu. Nasıl konuşma yapacak? İşte o sırada bu ilaçlar devreye girmesi gerekiyor. Boyun kas spazmı da çok kötü arkadaşlar. Boyunda bir ağrı vardır. Sırtta kas spazmı, omuz kas spazmı bunların hepsi bir şekilde insanın sosyal aktivitesini, işini, gücünü engelleyen önemli problemler. Bazılarında çok daha sık görülür. Onun için kasların güçlendirilmesi önemli. Ama bu ağrı spazm dengesini mutlaka ne yapmamız gerekiyor? Kısır döngüyü bir yerden kırmamız gerekiyor. Tabii bizim şöyle bazen oluyor, burada biliyorsunuz bu yıl yapamadık ama futbol turnuvası oluyordu. Futbol turnuvasında bazen biz de oynuyorduk. Mehmet Hoca ile falan işte bir yıldır oynamamışsın birden oynuyorsun. Tabii ne olacak? Kaslar ertesi gün bütün kaslar tutulmuş oluyor. Futbolcular neden ısınma hareketi yapıyor? Çünkü kasların birden hareket etmemesi için demek ki burada korunmak lazım. Yine yemek yedikten hemen sonra egzersiz yapmayın. Hani yemekten sonra yürüyüş yapalım diyenler. Mesela Zeynep Hoca 2'de 1 tutturur. Orada konuşuyor, bizi dinlemiyor. Zeynep Hocam yemekten sonra yürüyüş bak kas spazmı nedeni oluyormuş. Kahve, çay ve çikolata gibi bol miktarda nikotin içeren besini az tüketin. Kahve, çay, çikolata gibi bol miktarda. Allah Allah. O zaman biz niye sigara içmiyoruz? Madem bunlar nikotin bu kadar içeriyor diyorsun. Bunlar mı nikotin içeriyormuş yoksa falan diye düşünmek lazım. 2 litre su içmemiz lazım. Süt, portakal suyu, muz gibi kalsiyum, potasyumdan zengin besinler ve stressiz bir yaşam diliyorum sizlere. Bu nasıl yaşanıyorsa. Sonuç olarak arkadaşlar tedaviye geçeceğiz. Tedavide bakın ağrı kesici yazarken aklımıza gelen en önemli şeylerin başında nedir? Şimdi Murat Seyit önümde olduğu için soruyorum. Ağrı kesici de ilk aklına gelen ne? Yazarken ne düşünürsün? He? Hızlıca etki etmesi. Bu ofansif, bak ofansif duygu. Bu duyguyu yaşayanlar genelde farklı. Ama eğer şöyle deseydin ki o önemli, yani mesela hızlı etki değil de mesela başka ne denebilir? Atakan'a soralım yanında. Atakan. Ha işte bak bu da defans. Bak biriniz defans, biraz ofans. Şimdi defansif olanlar şöyle düşünür. Zarar vermeyin. Bunların tıptaki kuralı şu. Önce zarar verme. Aman ilaç veriyoruz, zarar vermesin. Bu futbolcu olsa defansta oynar yani. Gol yemeyeyim der yani. Diğer taraf ise hızlı etki etsin. Bu işe gol atayım, kazanayım. Bunların tıptaki karşılığı ne? Salondan alalım. Sema sen duymuşsundur, söyle karşılığını. Yok. Bu diğerleri önce zarar verme. Bunlar önce yarar ver prensibiyle hareket ederler. Onlar diyorlar biz gol atalım da golleri sonra bir şekilde çıkartırız. Gol yesek de olur. Gol atalım önce. Sonra bir de. Ama şu ağrı kesici yazarken bunları düşünüyoruz ama ilaçları düşünürken de güven duygusunun çok önemli olduğunu görüyoruz. Güven duygusu. İşte burada mesela 20 yıl, 30 yıl, 40 yıl kullanılan ilaçlar güven konusunda biraz daha ön plana çıkıyorlar. Hele kendi deneyiminiz de olmuştur bu ilaçlarla. Bu önemli. Dolayısıyla tedaviyi yaparken semptomatik yapıyoruz. Güven duygusuna önem veriyoruz. İlaca güveniyoruz. O ilaca güveniyor olmamız lazım. Tabii burada fizik tedavi yapılabilir. Lokal ısı uygulamaları yapılabilir. Bazen soğuk uygulama gerekiyor. Eklem içi enjeksiyonlar var vesaire. Cerrahi tedaviye kadar gidebilir. Ama hem analjezik hem de miyorelaksanlar bize bu konuda yol gösterecektir. Bir an önce tedavi olmak istiyor. Bir an önce işine dönmek istiyor. Daha doğrusu o ağrıyla işi yapmak zorunda. Ağrısını azaltmak zorunda. Çünkü çoğumuz bu ağrıyla yaşamayı öğrenmek zorunda kalıyoruz. Dolayısıyla stresin de ağrıyla birlikte olduğunu söyleyerek arkadaşlar şimdi sözü başka bir yere bırakayım ama bizim acil pratiği açısından şunları söyleyebilirim. Bir ilaç veriyorsanız mutlaka güvenmek istiyoruz. Hemen mide rahatsızlığın var mı diyoruz. Acaba bir perforasyona sebep olabilir miyim diyoruz. Bu konuda işte ilaç dikkat ediyoruz. İkincisi yine hani burada uydu sempozyumu rekordat ile yaptığımız için söyleyelim. Feniramidol hem miyorelaksan etki ki bunları Markın Bey anlatacak, hem analjezik etkiyle kısır döngüyü kırıyor. Güven duygusu oluşturuyor ve etkili analjesi, ama bizim için bir kolaylığı daha var biliyorsunuz. 40 yıldır kullanıyoruz. Bir intramüsküler yapıyorsun, bir tablet formu var. Bu da buna özgü olarak diyorum ve burada sözü bitiriyorum. Hepinize teşekkür ediyorum. Siz ben anons edeyim hocam. Profesör Doktor Barkın Berk Altıntaş Üniversitesi'nden daha önce de misafir etmiştik. Bu konularda uzman olan bir hocamız. Buraya geldiği için, teşrif ettiği için teşekkür ediyorum. Buyurun Sayın Hocam.
Efendim, hoş geldiniz. Tamam, zorlamayalım. Buradan konuşalım, sıkıntı yok. Efendim hoş geldiniz. Şeref verdiniz. Hem sizler hem uluslararası konuklarımızla beraber burada olmak oldukça güzel benim için. Çok basit bir soruyla başlamak istiyorum. Eğer sizin için uygunsa. Genç, yaşlı, erişkin hepsinin ortak problemi her geldiğinde ne oluyor? Ağrı. Tabii ağrı dediğimiz zaman ağrı ile ilgili olarak birçok şey söyledi hocam. Bağlantılı olarak spazmla ilgili de birçok şey söyledi. Bütün bunların hepsinin temel kaynağında, özellikle mesela spazmın temel kaynağında bir homeostatik dengenin bozukluğu söz konusu. Dikkat ederseniz replasman tedavilerin hepsi aslında homeostatik dengenin tekrar yerine getirilmesiyle bağlantılı olan, özellikle iyonik dengenin yerine getirilmesiyle bağlantılı olan tedaviler. Bunun haricinde 2 tane opsiyonumuz var. Ya analjezik vereceksiniz ya antiinflamatuar vereceksiniz. Başka bir çaremiz yok baktığımız zaman. İşler gençken ve erişkinken güzel de yaşlanmaya başladığımız zaman işlerin rengi değişiyor ve bu ağrı durumu, kronik ağrı durumu, kronik enflamasyon durumu çok fazla bir arada görülmeye başlanıyor. Çünkü aslında kas da yaşlanıyor. Kas yaşlandığı zaman normal olarak vücudun verdiği standart cevabı veriyor, enflamasyonu oluşturuyor. Kasın enflamasyonu oluşturması çok kolay bir şey çünkü buradaki şekilde de gördüğünüz gibi, özellikle altta gördüğünüz gibi kas aslında hücresi olarak bakıldığınız zaman birden fazla nükleosa sahip. Dolayısıyla çok ciddi anlamda herhangi bir durumda hemen hızlıca kendisini onarmaya yönelik olan bir yapı. Tabii otomatik olarak da herhangi bir cevap vermesi gerektiği zaman enflamasyonla karşı karşıya kalıyoruz ve bağlantılı olarak da hemen gene sizin şu anda sağ tarafta gördüğünüz enflamasyon durumu söz konusu oluyor. Yani kasların arası enflame olmaya başlıyor. Aynı şeklin bir başka görüntüsünü burada sol tarafta görebiliyorsunuz. Enflame oldukça aslında kas lifleri hafif hafif birbirlerinden ayrılmaya başlıyorlar ve arası şişmeye başlıyor. Tabii enflamasyon beraberinde kendi medyatörlerini de getiriyor. Enflamasyonun medyatörleri çok enteresan. Enflamasyon medyatörleri bildiğiniz gibi aynı zamanda ağrıyı da tetikleyen medyatörler. Özellikle nosiseptörler üstüne çok ciddi anlamda etkililer ve sensitizasyonunu sağlıyorlar. Ağrının en kötü tarafı şu: ağrıda bir ileti gerçekleştirdiğiniz zaman ağrı yukarıya kadar gidiyor. Yani hani yukarıya kadar, beyine kadar geliyor fakat cevabı oluşturulamayan bir durum. Yani bir respons veremiyor vücut buna karşı. Sadece diyor ki ağrı var, ağrı var, ağrı var. Bunu bir şekilde gidermen lazım. Bu durum erişkinlerde ve yaşlılarda, özellikle yaşlılarda çok daha fazla gözlemleniyor. Çünkü bu enflamasyon sonucunda çok ciddi anlamda aslında kas kendisini tamir etmeye çalıştıkça da protein consumption'ı, protein tüketimi çok artıyor ve ortadaki durum daha da kötü hale geliyor. Özellikle vücuda binen, böbreklerin üstüne binen yük açısından baktığımız zaman. Mekanik veya non-mekanik herhangi bir etkenle karşılaştığımız zaman bir doku hasarı var. Doku hasarı evet ağrı olarak kendisini gösteriyor. Homeostatik denge bozuluyor. Dolayısıyla spazm olarak kendisini gösteriyor ve cevap olarak da enflamasyon olarak kendisini gösteriyor. Dolayısıyla aslında baktığımız zaman ağrı, enflamasyon ve spazm birbirlerini tetikleyen durumlar. Enflamasyon daha da fazla tetikleyici halde, ağrının ana kaynağı bir önceki slaytta gördüğümüz medyatörleri yüzünden. Peki güzel de hani akut mu kronik mi, her zaman standart sorduğumuz soru. Akut olduğu zaman bizim için iyi bir şey. Hani nereden kaynaklanıyor, nasıl kaynaklanıyor bunu gözlemleyebiliyoruz. Ama akutun ilerleyen safhalarında, yani enflamasyon cevabı oluştuktan sonra endotel hasarı başlıyorsa, dokuda ciddi anlamda ödem gerçekleşiyorsa veya doku bütünlüğünün bozulması başlıyorsa, o zaman bir fasit daire haline geliyor ve doku hasarı sürekli kendisini yeniler bir duruma geçiyor. Tabii biz bunu hani kronik olarak CRP'nin falan filan çok yükselmediği durumlar da söz konusu bu arada. Ama yani hani akutta gördüğümüz kadar çok fazla gözlemleyemiyoruz. Ama vücut içten içe kendisini hırpalamaya ve dokusal olarak hasar vermeye devam ediyor. Şimdi burada ana hani spazmdan başladık. Ağrı ve spazm için 2 farklı grup ilaç kullanıyoruz ama acaba 2 farklı grubu birleştirmek söz konusu olabilir mi? Veya bir birleşik olsa bu 2 farklı durumu ortadan kaldırabilir mi? Biz çalışmalarımıza başlarken bunun üstünde çalışarak başladık ve tabii ki çeşitli antispazmolitikler artı tabii ki antiinflamatuar ve analjeziklerin hepsini birden bakmaya başladık. Analjezik antiinflamatuar sadece non-steroidal antiinflamatuarlarda var. Yukarıya doğru gittikçe aslında durum biraz farklılaşıyor. Yani opioidlere doğru gittiğiniz zaman durum birazcık daha farklılaşıyor. O zaman enflamasyonu ortadan kaldıramıyorsunuz. Bunu birleştiren bir tane yapı var mı diye bakarken feniramidol önümüze çıktı. Feniramidol baktığımız zaman hani doz olarak 400 mg film tablet olarak günde 3 kez kullanabileceğiniz, 1 veya 2 tablet halinde veya 800 mg'lık 3 mililitrelik enjeksiyonluk çözeltisiyle kullanabileceğiniz bir birleşik. İlginç olan tarafı çok hızlı etki gösteriyor. Yani ilk 10-15 dakikada etkiye başlıyor ve maksimum yarım saat içerisinde etkisini maksimize edebiliyor. Tabii bu özellikle acil serviste çalışıyorsanız sizin elinizi çok kolaylaştıran bir durum. Çünkü çok hızlı bir şekilde aslında cevap alıyorsunuz ve bu cevapla beraber de fenomenal özelinde hızlı bir şekilde hastayı rahatlatabiliyorsunuz. Özellikle spesifik olarak kas iskelet sistemi akut ağrılı kas spazmlarının semptomatik tedavisinde endikasyonu var. Hem ağrı hem spazm açısından baktığımız zaman. Feneramidolün çok enteresan bir özelliği var. Verdikten sonra, dolaşıma geçirdikten sonra biriktiği yer aslında kas kütlesinin kendisi. Yani spesifik olarak dağılıma giriyor, kasta depolanıyor, tekrar dağılıma kastan devam ederek yavaş yavaş salınarak devam edebiliyor. Feneramidolün ikinci bir özelliği daha var ki özellikle bir nöropatik durum söz konusu olursa, düzensiz sinir iletimi durumu söz konusu olursa feneramidolün kendi metabolitleri de ilaç olarak kullanılabiliyor. Bunun yanı sıra asetilkolin salınım kavşaklarında herhangi bir şekilde değiştirmeksizin düzenli iletim sağlayabiliyor sinir hücresinin üstünde ve de bağlantısı olarak da eğer hasta kronik spazm geçiriyorsa spazm oluşturma özelliğini veya spazm oluşma olasılığını da düşürüyor. Tabii ki mutajenik ve genotoksik etkisi de bulunmamakta. Baktığımız zaman feneramidolün en büyük olaylarından bir tanesi, yani enflamasyona giden yolda niye feneramidol çalışmayı seçtiniz, niye bu konuda kafanız hani gidip de feneramidolü nereden buldunuz derseniz aslında prostaglandin yolağı üstünde de etkili olması. Çünkü ağrı mekanizmasını aslında prostaglandin mekanizmasını inhibe ederek sağlıyor. Prostaglandin E2'yi inhibe ediyor ve nosiseptörlerin de bu şekilde uyanmalarını azaltıyor ve periferik sinir ucunda da bu uyarıyı oldukça düşük seviyeye çekiyor. Ağrı oluşum eşiğini de supraspinal ve spinal seviyede de arttırıyor. Bizim işimiz sizinkinden biraz farklı. Bizim işimiz hasta ile değil, bizim işimiz moleküllerle. Moleküller dediğimiz zaman birçok farklı molekülü aslında özellikle başka bir etkisi var mı, nasıl bir etkisi var şeklinde deneyerek işimize devam ediyoruz. Daha önce yaptığım konuşmalarda bunlardan bahsetmiştim. Aslında bu bir repurposing çalışması ve de hani feneramidol yapısal olarak da aslında siklooksinaz enzim inhibisyonu gösteren yapılara çok ciddi anlamda benziyor. Ama buradaki kritik kısım şurası. Santral sinir sistemi depresyonu yapıyor mu, yapmıyor mu? Feneramidolün bir özelliği daha var ki santral sinir sistemine geçişi çok az. Biraz sonra başka bir deney setiyle beraber bunu tekrar söyleyeceğim. In silico çalışmalarda gerçekten de siklooksinazın aktif yöresine etkisini çok net olarak gözlemleyebiliyoruz. Şimdi geçmişte yaptığımız çalışmalara ek olarak bir kısım yeni çalışmalar daha yapmaya başladık. Özellikle feneramidolün kendisinin adsorpsiyon, dağılım, metabolizasyon, eliminasyon açısından diğer nonsteroidal antiinflamatuarlarla veya diğer antispazmolitiklerle karşılaştırdığımız zaman durumu nasıl bunu gözlemlemeye çalıştık yaptığımız çalışmalarda. Bunlar da aslında in silico çalışmalar fakat klinikteki genel durumla da şu anda örtüşür vaziyette. Oral absorpsiyon açısından bakıldığı zaman feneramidol %100 absorbe olabilen bir molekül ve ilginç şekilde pasif transportla bağırsak lümeninden hızlıca geçebiliyor. Yani %100 bağırsak lümeninden transfer edebiliyorsunuz. Bu iş için herhangi bir ek kuvvet kullanmıyor vücut. Çok rahatlıkla bağırsak lümeninden dolaşıma pasif transportla geçirebiliyor. Serum albümüne bağlanma oranı oldukça düşük ve aynı şekilde de pasif transportla kan doku epiteline geçiş sağlanabiliyor. Bu da bizim çok hani gene kas dokusu üstünde nasıl rahatça depolanabildiğinin bir göstergesi aslında bizim açımızdan. Yani kasta depolanıyor, kasta depolandıktan sonra salınıyor diyoruz ama hani gerçekten böyle bir durum var mı? Gerçekten de var. Yaptığımız çalışmalar ciddi anlamda da dokuya çok hızlı transport olabildiğini, enerji gerektirmeden transport olabildiğini gösteriyor. Aynı durum dolaşım kan-beyin bariyeri içinde geçerli. Kan-beyin bariyerini çok az geçen yapılardan bir tanesi feneramidol ve bağlantısı olarak da santral sinir sistemi depresan aktivitesi aslında diğerlerinden çok daha az, neredeyse yok denebilecek durumda. Bunun haricinde ikinci önemli olan şey, özellikle yaşlı hastalar açısından, biliyorsunuz yaşlı hastalarda demin bahsettim, protein yıkımı çok yüksek miktarlara vurabiliyor. Dolayısıyla çok ciddi bir böbrek yükünüz var. Siz kronik bir antiinflamatuar, kronik bir antiinflamatuar kullandığınız olarak veya kronik bir ağrı kesici kullandığınız zaman en büyük probleminiz böbreklerde oluşturduğunuz yük oluyor. Dolayısıyla bakıldığı zaman böbrek üstündeki, yani böbrek hücrelerinin üstünde de bir toksik etkisi olup olmamasını da bakmak zorundayız. Sağlıklı insan böbrek hücrelerine baktığımız zaman fenüramidolün sitotoksik etkisinin çok çok düşük olduğunu gördük. Diğerlerine oranla aslında böbrek hücrelerini çok daha az hırpalıyor veya çok daha az yaralıyor bir ağrı kesici ve antispazmolitik olarak. Tabii bunun yanı sıra bir de kalp krizi oluşturma riskimiz var biliyorsunuz. Özellikle kalp krizi oluşturma riski nonsteroidal antiinflamatuarlarda her tipi potasyum kanallarının inhibisyonuna dayalı olabiliyor çoğu zaman. Baktığımız zaman bunu da fenüramidolün çok az bir miktarda yaptığını görüyoruz. Diğerlerine oranla inhibisyon, her tipi potasyum kanallarının inhibisyonu çok düşük. Tabi hemen buradan enflamasyon sonuçlarına geçmek lazım. Gene enflamasyon için yaptığımız sonuçlarda, yani antiinflamatuar sonuçlarına baktığımız zaman da siklooksingenaz 1 ve 2'yi diğerlerine oranla daha dengeli olarak gerçekleştirdiğini görebiliyoruz in vitro eseylerde. Aynı şekilde ağrı için baktığımız zaman da ağrı kesici etkisinin diğerlerine oranla çok daha yüksek olduğunu görebiliyoruz hayvan deneylerinde ve gene hayvan pençe ödem testlerinde antiinflamatuar aktivitesi ibuprofene oranla daha iyi, dexametazona benzer olduğunu gözlemleyebiliyoruz. Buradaki en önemli şeylerden bir tanesi bizim dokunun içerisindeki o stokinleri veya mesajları dengede tutuyor olmamız. Çünkü günün sonunda enflamasyon bir cevap ve enflamasyonun temel mantığı da dokunun iyileştirilmesine yönelik olan bir cevap. Doku iyileştikçe enflamasyon azalıyor aslında kademeli olarak. Ama bu azalım, yani bu dokunun iyileşme sürecini hızlandırabilir miyiz? Veya antiinflamatuarlar bu dokunun iyileşme sürecini geciktiriyor mu kullandığımız zaman? Sorulardan bir tanesi bu. Birçok antiinflamatuarın ortak olarak yaptığı şeylerden bir tanesi özellikle interleukin 1B ve TNF-alfa'nın aynı anda inhibe edilmesi ve dolayısıyla dokunun tedavisini geciktirebiliyorlar veya daha net söylemek gerekirse tedavi için gerekli olan moleküllerin birbirleriyle haberleşmesini bir miktar engelleyebiliyorlar. Fenüramidolün böyle bir özelliği yok. Özellikle iletişim bozmadan aktiviteyi gerçekleştirebiliyor. Bununla bağlantılı olarak da tabii hani bir kısım yayınlar yaptık ve yayınları yapmaya devam ediyoruz. Klinik araştırmalarını da yapmaya devam ediyoruz. Bu en son fenüramidol ile ilgili olan çıkan araştırmalardan, klinik araştırmalardan bir tanesi. Yaklaşık 100 hasta üstüne yaklaşık her biri 400 mg'lık 1 veya 2 tablet olmak üzere 3 veya 7 gün boyunca günde 2-3 kez fenüramidol uygulaması yapılıyor ve daha sonra da sayısal ağrı değerlendirme ölçeğiyle hastaların genel durumu ölçülüyor. Bu ölçek hem hastalara uygulayabildiğiniz hem de hekimlere uygulayabildiğiniz bir ölçeklendirme sistemi. Sonuca baktığımız zaman hekimlerin %89'un ciddi anlamda global etkinlik değerlendirmesinde fenüramidolü başarılı bulduğunu görüyoruz. Hastaları da mükemmel olarak %43 derecelendirilmiş, iyi olarak %38 derecelendirilmiş, orta olarak %15 derecelendirilmiş ve zayıf olarak %4 derecelendirilmiş. Dolayısıyla totale baktığınız zaman neredeyse %70-75'ler oranla iyi ve mükemmel kategorisi içerisinde hastalar tarafından da seviliyor. Fenüramidol kullanıldığı zaman da memnuniyet yaratıyor. Efendim dinlediğiniz için teşekkür ederim. Tekrar sağ olun, var olun.
Evet, çok teşekkürler Hocam Hocam. Arkadaşlar soru katkı kısa bir süre için alabiliriz varsa. Şu anda salonda herhangi bir soru katkı göremiyorum. Zaten anladığımız bir konu, hepimizin muhatap olduğu bir konu. Hepimiz bu konuda deneyimlerimizi paylaşabiliriz. Ama bu kadar vaktimiz yok. Hepinize katkılarınız için buraya geldiğiniz için teşekkür ediyorum. Ve şu anda program devam edecek burada ve diğer salonlarda. Ona göre herkes görevli olduğu veya dinlemek istediği yere gitsin ama salonlara gitsin. Başka yere gitmesin lütfen. Bu şeyi de bitirelim. 2 saatimiz kaldı bugünün. Şunun şurasında çarşambaya ne kaldı diyorlar. Onun gibi bir şey yani. Bekliyoruz arkadaşlar. Evet.
Globulins also decreases. I don't want to go into the deeper in depth into the immunological aspects of the immunosenescence, but to categorize, we can summarize the issue in that context. Okay. So this
20 minutes over.
it's, yeah, I'm finalizing 1 minute. So according to the study of Dr. Yahau, it's an meta-analysis. They have shown that when we look at the fever in the elderly population, the median of the fever in these studies is 77%, which means 1/4 of the patient population cannot mount fever response in the elderly. The second one, in some of the studies, it was noted that when the patient is getting elder, compared to young elders, fever response is coming less. The fourth issue, when we look at the hypothermia, which means the detection of human body temperature below 35 Celsius degrees, approximately 2% of the patient population in the elderly, hypothermia is obvious. And one of these studies published in Journal of American Geriatric Society journal, they have noted that when the patient admitted to the hospital with central line, with previous surgery, with gastroenterostomy, with urinary incontinence, or if the patient has an expectation to die within 3 months, or if the patient is obese or male, then the bacteremia is likely in this group. This is an historical, record. Sir William Osler, in his internal medicine textbook, previously noted that pneumonia can be defined as captain of the men of death, because at that time, in the colder seasons, everybody has the potential to acquire pneumonia, community-acquired pneumonia. And according to our study, we have recruited the data from the historical records of the Turkish General Staff Headquarters. We have seen that the basic aim of this study was to analyze the natural courses of the infections in the absence of antibiotics. So we have seen that pneumonia has 31% mortality 100 years ago in the absence of antibiotics. So most likely to be the bacteremic form at the ultimate stage, community-acquired pneumonia is a significant issue compared to other types of infections which are most likely to be related to the compromised infrastructure in the countries, earthquakes, war times, etc. But pneumonia is an endemic disease and can be seen in colder seasons. So pneumonia is a critical issue which is reflected with other studies which shows as respiratory system as the main sources of bacteremia. So I'm finalizing. And this is the nosocomial bloodstream infection agents in the elderly population. They have included fungi too. But gram-positive bacteria are slightly less than gram-negative bacteria in this group. And, advanced age, presence of intravenous catheters and being bedridden are the major parameters that result in the bacteremic courses. Finally, this is my last slide. In the rational management of bacteremias, first, the microbiological diagnosis is excessively important because no antimicrobial therapeutic modality is reliable in our age. Anytime we can see a drug-resistant microorganism that the antibiotic we have provided is not working on, And the second issue is infection control and prevention. This is the basic issue to prevent the dissemination of problematic microorganisms from one patient to other patient. And the third one is the source control. Time to time we have in the management of problematic infections, we have real problems in that context. And the last one of the most important point of view is to integrate local data to our therapeutic recommendations. Because most of the time the international guidelines uses their local epidemiology. If you are following an American guideline, they are using American epidemiology. So to optimize therapy in the optimization of management, anti-infective management of the patient, we should integrate our local data into our therapeutic recommendations. Thank you very much.
So that was an excellent presentation. I think we'll take the questions in the open session. We'd like to go for the next speaker. That's Dr. Mohammed Hanif. He'll be speaking on geriatric emergencies and its unique challenges in an ED. Very good evening all. So now we are at the session where we'll be discussing about geriatric emergencies. So geriatric emergency and its unique challenges is what we'll be discussing today. As an effect of having a very good advanced healthcare and giving a good quality of life, our population, especially elderly population, is more nowadays. And it's not just in developed countries, it's also seen in developing countries also. A very good example is in India. Previously, to have an elderly population that is above 65 years old, on a lesser number comparing to now. When we look at the data in India, if you can see that there's an increase in more than 10% of geriatric population in last 2 decades. This all showcases the importance of having an exclusive care for geriatric age group. We would be wondering, what is special in a geriatric than an adult? How a pediatric emergency department has a role in managing pediatric age group. Similarly, a geriatric age group is also little different. Their problems are different from an adult. So what is a geriatric age group? If you look at WHO's definition, it says when you're more than 65 years, that age is considered as a geriatric age. So we'll be discussing about certain unique aspects of geriatric age. What are their challenges? You'd be wondering, what is the importance of a geriatric age group? There's a specialty called as geriatricians are there to take care of it. But when you look at the data of any emergency department across the globe, you can see that nearly 40 to 50% of our patients are from the geriatric age group. Yes, we do get a lot of younger age group, but still, if you look at the data across the globe, not just, I have a couple of data from India, but still, if you look across the globe, we have a very good number of population who falls in the geriatric age group. It's very much depicted in the picture here. You can see the age group is more than 30%, especially in most of the countries across the globe. In certain countries, it's more than 30%. So the population is growing and it's even expected to grow more by 2050. So the amount of geriatric patients we are going to handle is going to increase a lot. So let's see what are the unique challenges in this age. So in the demographics, if you look at the demographic, nearly in United States itself, the population is expected to double by 2060. And 12 to 24% increase in the geriatric emergency patients is estimated in both developed and developing countries. And an aging population has significant implication for healthcare, particularly emergency medicine, because they form a major chunk of emergency department patients. So geriatric patients, on average, a substantial population of ED patients are majorly elderly individuals, which we already told. These patients present a wide range of issues. They need specialized care due to their age-related changes and comorbidities. So like how a pediatric age group requires a special area for care, a geriatric age group also requires a special area of care and special policies, protocols, and their unique challenges has to be addressed. So this is a distribution of clinical symptoms or complaints with which the patient comes to an ED in India. So it is based on a study that we can see the most common complaint is highest percentage presenting is 13% with shortness of breath. The most of the patients, elderly patients come to emergency in ED, they presented with shortness of breath. And second highest was angina. And the third highest was having a non-specific chest pain and upper GA bleed and other major distribution of non-specific complaints. So this non-specific complaints in elderly population, especially they always have a fear of having some issues, so they come to ED very often, even with certain non-specific symptoms also. All this adds to the burden of emergency physician in order to take care of them. So like how it is very demanding for a pediatric population, geriatric population also at time is very demanding. Their relatives will be there, their kids will be there. They'll be asking a lot of questions what's happened. So I think it's like how now you can relate how in a pediatric population comes, the parents are very much concerned. The same way the geriatric patient comes inside, their relatives also very much concerned about their father, grandfather, XYZ. So in this age we can see is like there's adequate amount of trauma and also poisoning, some bites and urinary tract infection, and also malignancies and psychiatric illness. All these contribute us to make think and develop a unique area or unique way of approaching these patients. The geriatric patients pose a unique challenge for healthcare with the following issues. Like one is cognitive impairment. So in most of the patients, because of their cognitive issues, it will be very difficult to take proper medical history. The patient might have come in and unresponsive. You need to ask, because many times they'll be staying alone. It's very difficult to take history and ask what happened to your parents. They said, we found him unresponsive. He was found unresponsive. He's not talking now. He's not moving his leg. What happened? Nobody knows. So that puts us in a very difficult situation to make a diagnosis or evaluation. Communication, especially hearing issues. So when the patient comes inside, that makes you cannot just talk to them like that. So maybe you have to be a little louder. So you don't understand, because you'll be asking questions, they won't be responding back to you. So this puts you in a lot of, all these, you might be routine thing, it's another patient will be asking, you'll be answering, and you'll be giving wrong answers. He might be having some mild delirium. So all this puts us in a lot of difficult situations. So that's why we have to understand this is a special age group where we have to focus on these issues, keep them in mind while approaching these patients. And frailty also very important. Most of the elderly patients, psychology research and response to stresses are very low. So they may get immediately agitated, irritated. So you should be very, compassionate in approaching these patients. So if you come in pediatric also similarly we do. We try to be very compassionate with the child. We try to understand from the parents what the issues are. So similar way in geriatric age group also a lot of challenges are there. So a comprehensive clinical assessment is very important in these patients. It's because first of all we know that because of their cognitive issues we won't be able to communicate with them properly, comorbidities and also frailty. It will be difficult to elicit all clinical history exactly and get an information what we need specifically for our clinical assessment. So there comes an important tool which we use is called 4Ms, which is based on mobility, medication, mind and most matters and goals and values. A geriatric focus history and physical examination is essential for accurate diagnosis and treatment. So here comes the 4M screening tool. First is mentation. Confusion assessment method score or CAM score can be used, where you can ask questions to the patient and see whether he's having a proper response to the answers. We'll be discussing about it later. In mobility, ask for mobility, whether there was a fall within the last 3 months. Because many times they will come and tell, my father is not moving his leg from today morning. So you'll be asking what happened. I don't know, nothing, everything was fine. Today morning he is not moving. But there might be history of fall which went unnoticed, or the caretaker was not experienced enough to appreciate that. Use of walkers, cane or mobility devices, and currently feeling dizzy or faint, currently on any fall precaution, because he has a high risk of fall. Because many times patients have a small trivial falls which translate into fractures or bedridden, and they come to us. So if any fall precaution is advised, it means that he has already in a risk, patient is a risk for getting injury due to fall. And completion of fall risk education, time up and go test has to be done. And if there is answer to any of these questions, there is an abnormal time up and go test, it means that there is affected the mobility. Then medication. Medication is also very important, because one of the unique challenges of geriatric population is polypharmacy. They'll have multiple comorbidities, multiple clinical issues. They'll be on multiple drugs. So you should have a proper idea of what current medication that have, and recommendations is based on AGS base criteria that we'll be discussing soon. And if that is done, then a positive medication scheme is done. What matters is, like, is there any advanced directive or living will? Like the patient is telling, okay, if he's in a cardiac arrest, please do not resuscitate, or anything else. Who should make decision for him when he is critically ill? Because when these patients come, they are not in a position to make a decision for themselves. So we should find out who can make a decision. Is it a son, wife, or his relative, or his friend, or his attorney, who has to make a decision for his clinical management? Another reason for geriatric referral, and that has to be taken into account. So this is how a geriatric patient's workflow has to be established in an ED. The patient arrives, the patient is done triaged by ED nurse, and the ED nurse puts in triage criteria where if it's more than 65 years, emergency severity index 1, 2, 3 or 4, that has to be done. And then the geriatric EM, that 4M assessment is done. And then as per that, the patient is admitted in an area, and current workup and diagnostics are done, specific checkups are done, disposition is planned. Our patient is given to a particular supporting system, and a public supporting system, who can take care of the patients even if the patient is discharged from the home. So social workers, all this has to be included. So it's a chain of event which has to be established. So this is a workflow which is being recommended, and what they say is, like, each hospital or each country has their own way of handling their geriatric population. So we can adapt from this and establish a workflow in the system where the geriatric patient is followed up completely. So this is a distribution of geriatric patient in our in EDs in India. When we saw that nearly more than 60 years, in a year we had more than 3,153 male patients, and female patients are 2,246 patients. And we tried them on the base of ESI. Their level 1 patients were 891, level 2 was 1,583, level 3 was 2,148, and level 4 was 557, and level 5 was 221. And you can see level 3 and level 2 patients constituted the highest number of patients coming to our emergency department. Among these, nearly 21% of patients had ED admission, and 38% patients were discharged, and nearly 1.8% had expired or had a cardiac arrest or other clinical condition in emergency where they died in ED, and broader patients were 3.6%, and nearly 1.3% went against medical advice. So mostly these patients, if you look at them, 78% admission is to ward, so they had minor clinical, and more than 21% they are admitted in intensive care unit. So the falls in elderly, when you look at the risk of falls in elderly, it's more in, it's 1.56 times more in females than males. And the most common cause is faintness, dizziness, and low blood pressure and muscle weakness in legs. So there are intrinsic factors and external factors. If you look at the external factors, slippery fall, tripping, and uneven surface collision and falling in downstairs are the most common way of presenting in ED. So it's multifactorial, and this multifactor has to be addressed in order to resolve this. It's like medication review, education on fall prevention, exercise programs, body health assessment, comprehensive risk assessment, home modification, polypharmacy and vitamin D supplementation, environmental hazard, physical therapy and professional support, and nurse review has to be done regularly in order to prevent this fall prevention. So delirium is another major issue faced by the patient. Delirium is an acute fluctuating change in the mental status. So this has to be done in 2 steps, where you have to do a first check for any altered consciousness. If it is present, then the delirium test is positive, and if it is negative, then ask for any question like, can you spell the word from backwards? If it is telling without any error, it means that EDS is mild error, its DTS is positive. If it is not, then DTS is negative. Then we can use a BCAM negative or no delirium algorithm. So medication polypharmacy is one of the most important challenges. So this can be addressed with AGS-based criteria. So AGS-based criteria is a very elaborate thing which we can have in our department when we are dealing with these elderly patients. So I'll not go into very much detail into that. So these are a couple of drugs which are recommended specifically to be avoided or not used. So dehydration is also one of the major issues. Most of the elderly population dehydration because of their the physiological changes and poor retention of water, poor intake of water and excessive urination and other insensible losses. And frailty is the most important state of vulnerability to stresses or impact factors. That is like aging, genetic, lifestyle and environmental diseases can cause frailty in elderly, which results in like weakness, weight loss and exhaustion and low activity and slower performance. And as a result of that, they may have falls, disability, dependency, surgery risk and death. So pain management, so you can see we can use appropriate analgesics for the patient based on this scale. So we can use severe, means you can use opiates, moderate means you can use NSAIDs, mild also NSAIDs like acetaminophen, and muscle relaxant and other things can be used accordingly to the severity of the pain. But in geriatric age group, we should follow the base criteria and only use the following drugs which are highly recommended like amitriptyline, ketorolac and other drugs, and certain drugs has to be avoided. Another most important challenge is having pressure ulcers and skin care, which we many times tend to miss because especially these are on the dependent areas like ear, shoulder, elbow, hip and thighs. Whenever a geriatric patient comes, especially from a home setting, if he's bedridden, please always check for any pressure ulcers or bed sores. So this is geriatric syndrome. Geriatric syndrome is where in the geriatric age group multiple issues come in like pneumonia, diabetes, renal dysfunction, cardiac ischemic cardiac diseases, dementia, depressive disorders. So it's a very complex condition seen in most of the geriatric age group. End of life care. So managing symptoms, patient wishes, spiritual well-being, asking if there is any need for any continuing care. Patient and family has to be counseled adequately. Breaking the bad news is a very important step in ED. If a death happens, emotional support and legal issues like any DNA, DNR, or who has to make decision, etc. And after that, what has to be done. Geriatric emergency guidelines. So this is how a geriatric emergency system should be set in, and this is based on the GED guidelines by the ASAP. And so this we can take as a model and maybe replicate in many EDs. So the most important recommendations is certain societies is do not prescribe a medication without conducting drug regimen review. That's very important because they are on polypharmacy. Do not assume a diagnosis of dementia in an older adult who present altered mental status or symptom of confusion without assessing for delirium. Never think that he is having a delirium without assessing properly with the proper tools which we already discussed, and avoid using prescription appetite stimulants or high calorie supplements for treatment of anorexia or cachexia in older patients. Optimize social support, discontinue medication that may interfere with eating, and provide appealing food and feeding assistance and clarify patients' goal and expectations. Thank you. Next, I would like to invite Dr. Rahul Balasubramaniam for delivering a geriatric analysis here.
Good evening all. I would like to thank Team Vasim and EPAT for giving me the opportunity to talk on the topic analgesia in elderly. So pain is considered as a sixth vital, and as a result, we need to address analgesia. As the overview, we are going to discuss the topic starting with prevalence and types of pain in elderly. So what are the challenges in geriatric pain management? Already Dr. Hanif has explained the challenges in general care of geriatrics. So what specific for pain? Pain management principles, pharmacological and non-pharmacological modalities, and in specific regarding opioid use in geriatrics, and also some pain management in special situations. So with the data, almost 49 to 83% of elderly individuals above the age of 60 may be in care homes or as well as in community has suffer from pain. And if it is not addressed properly, that can have serious complication too, like depression, anxiety, sleep disturbances, and mood changes, which will later on progress to some other serious complications too. So pain can be depending upon the location of the pain, like musculoskeletal, osteoarthritic, chronic joint, or peripheral neuropathy. This is only a small list. It can be depending on the location any. As well, we can have different type of pain according to the etiology also, like neuropathic pain, it can be a colicky pain due to spasms. So these are the types, and we need to have an assessment of the pain according to the etiology as well as the location. So coming to the challenges in pain assessment, there are a lot of misconception that after aging or as you age, the pain is normal and it is an accepted norm. It can be either from the caregiver or the practitioner as well as from the patient itself. So it is not like that. The pain has to be addressed. And often this leads to under-reporting of the pain. The patient might not report the pain thinking that, yes, this is fine. But we allow to use certain pain assessment tools to dig that out. The other contributing factors are visual or hearing loss and even cognitive impairment, including confusion, memory loss, or dementia, whatever it can be, or the delirium. And other problem is the fear of using proper or oligoanalgesia, which is usually happening, is the fear of adverse effects of the analgesics. So it is very important to use the correct analgesics at the right dose, and also be aware of the drug interaction and polypharmacy. So this is a study which comprises of 1,454 patients with hip fractures over the age of 65 years. I put this study to exemplify the fact that even though the pain was severe, the pain score was 7, over the 40% of the patients were not prescribed an analgesic, and there was no objective assessment done. So you can imagine there can be multiple reasons for the same, but the pain as such has to be addressed as treated. So the oligoanalgesia, if not treated properly, can lead to severe cardiopulmonary morbidity, long hospital stay, which can add on to the cost, then lengthier rehabilitation, frequent readmission of the patient, and even development of chronic pain syndromes. So physiological changes which are the challenges are the central nervous system, decrease in blood flow, which can lead to the altered perception and effective expression of the pain. Peripheral nervous system, maybe due to diabetic neuropathy, can lead to sensitivity to pain, temperature, or touch. In cardiovascular system, there will be decreased cardiac output. As a result, there can be increased toxicity of the drugs. In gastrointestinal system, due to decreased secretions, it leads to impaired dissolution of some drugs, and as a result, there can be decreased effect of drug as such. When we consider the liver or the hepatic system, it can lead to decreased protein binding, and as a result, increased free drug. So increased free drug in turn lead to toxicity. So we need to do the dose adjustment accordingly, whether it be hepatic or renal. When you consider renal, obviously as the age advances, GFR decreases, renal blood flow decreases, and as a result, half-lives also increase, and as a result, toxicity. When you consider musculoskeletal system, you know, as you ages, there is decreased body water and also increase in adipose tissue. So considering the lipophilic or the hydrophilic drugs, there can be either toxicity or there can be accumulation of the drugs. So you should consider these physiological factors before prescribing an analgesic in an elderly individual. So the part of comprehensive geriatric pain assessment, we have to directly go and ask the patient what is. Sometimes he might not be telling you the pain as such, it can be some discomfort. So you need to use the assessment tools and how it can impact the daily function. So it can affect even sleep, the mood, activity, as well as general energy of the patient. And also consider other comorbidities and the drugs which the patient is also using, because there can be a drug interactions which you are going to prescribe. So you should discuss with the patient as well as the caregiver regarding the goal. What is the goal of the pain relief you are going to get, and other expectations. So what are the available pain scoring tools with us? So we have a famous visual analog score, which can be used in cognitively intact patients. So it can be from no pain to worst possible pain. Okay. The other is numeric rating scale, which is numbered from 0 to 10, and 0 is no pain and 10 being the worst. And next is verbal descriptor scale, phases scale. And phases scale, you can see in the last row, it's usually used not in elderly, but in pediatrics. You can ask the child to indicate which is the phase or which is the type of pain he or she is affecting from. And the last two are mainly for the impaired cognition. So Dolopus 2 is used for impaired cognition individuals, and visual scales and assistive hearing devices can be used for assessing the pain in case of visual and hearing impairment. So this is all numeric rating scale, verbal descriptor scale, or the facial pain scale are all unidimensional approach. But most often in elderly, we can't stick onto a single dimensional pain assessment. We need to approach it multidimensionally, and for that McGill's pain questionnaire is a good tool which we can use, which indicates the pain location, temporal qualities, sensitivity to change. But it is not recommended for use in illiterate or cognitively impaired individual. For that, the option would be pain aid, which is used in dementia and non-communicative patient. Okay. So our aim is not to attain a zero pain. It is a practically a pain decrease or a accepted decrease in pain. And in the background of opioid epidemic and the adverse effects, we need to have some other options also, other than the pharmacological options. So we will aim for a balanced analgesia. So you can see the basic pain pathway, which starts from the peripheral receptors, going to the spinal cord via myelinated and unmyelinated fibers to the dorsal column, and then to the central pain centers. So here, in the pathway, you can have both pharmacological as well as non-pharmacological options. And this is the changing landscape in pain management. The ladder pattern has been changed. Previously it was 3 from mild, moderate, and severe. So previously only opioid or NSAIDs or acetaminophen were the only options. But along the ladder, we can use some sort of integrative medicine therapy, which includes regional nerve blocks, non-pharmacological therapies, and so on. And this is when we are going to give analgesia, let it be very specific according to the target. The target can be channel, enzymes, receptors. So it is a targeted analgesia approach. So you can see the different targets for appropriate analgesia. So the rule of thumb for elderly analgesia, we to start low and go slow. And on reassessment, if you want to increase, it can be done later. So to start with, the paracetamol, which is widely accepted across the globe, it is a safe drug to be used even for musculoskeletal pain and other pain also. And it doesn't have any anti-inflammatory action. So you should consider other analgesics for such anti-inflammatory action. And there is no antiplatelet action too. It is considered safe and not associated with any other side effects. So you can have a ceiling dose of 1000 milligrams per orally, and there is no superiority if you are giving it by intravenous route. So that has to be kept in mind. So when you talk about NSAIDs and selective COX-2 inhibitors, it should be started at low dose and should be for the shortest period and reviewed on regular basis because it can have renal, GI, bleeding, a lot of complications. So GI bleeding can be dose dependent. It can be depending upon the duration as well as the age. And if you are going to take it along with some antiplatelets, it is going to increase the risk of GI bleeding. And apart from that, if you are using it with a selective COX-2 inhibitor, you are not going to get the advantage of GI safety. And it's going to worsen your chronic kidney failure if used with diuretic as well as AC inhibitors. As you all know, it can increase water and sodium retention, edema, worsening of congestive cardiac failure. And COX-2 inhibitors are contraindicated in established ischemic heart disease and CVD. When coming to opioids, it's efficient in short-term persistent musculoskeletal pain as well as various neuropathic pain. But you need to think about the complication like sedation, nausea, and vomiting, and it resolves after 2 or 3 days. But the constipation, if at all is there, has to be treated with laxative therapy. And usually cognitive function is unaffected in patients taking a stable opioid dose. But when you escalate the dose, that can actually impair the cognition for up to 7 days. So in such case, you consider it as a switching or rotation, and a significant adverse events with one particular opioid is seen, you can switch it with another or rotate with another drug, maybe not opioid, or a lesser dose. And modified release oral or transdermal opioid formulation aimed at providing relatively constant plasma concentration. So usually we start with a 25 to 50% of the recommended dosage. And in severe pain, you can start with slow dose, and after frequent re-evaluation, you can slowly increase. Other drugs are codeine and dihydrocodeine. Next is tramadol, which is centrally acting with a weak mu opioid agonist and serotonin norepinephrine reuptake inhibitors also. So even though it's used, it has to be used carefully because it can even precipitate seizures and also serotonin syndrome if mixed with some drugs. And always 20% less tramadol than younger adults. So the drug regime is to start with 25 milligram once or twice daily, increase by 25 milligram if increments, and finally a goal of 100 milligram per day. And coming to the morphine, it has a similar efficacy to neuroopioids such as oxycodone. It has a hepatic metabolism where morphine 6-glucuronate and 3-glucuronate and produce the analgesic effect and also the neuroexcitatory effect. It goes and has a continuous enterohepatic circulation, and if you have a renal impairment, and it is not going to be excreted through the feces or urine, and that can accumulate in case of renal failure, and so you need to have a dose adjustment. The regime for initiation will be 2 to 3 milligram every 6 hours with a plan to follow up with 2 to 3 days to assess for efficacy as well as adverse effects. Next is oxycodone. Fentanyl. Fentanyl is an effective drug which can be used in its analgesic dose, much less than the induction dose. Very safe drug if given properly and monitored. And also there are few complications which we see rarely given analgesia like chest rigidity, or which is not seen for analgesic dose of fentanyl. And transdermal fentanyl and also intranasal fentanyl in case of pediatrics can be considered. So usually transdermal fentanyl must not be used for the opioid initiation and should only be used in context of opioid rotation or switching. So there is because of the opioid overdose or the potential side effects, other drugs were considered. One among them is the subdissociative dose of ketamine, the JURIKIT trial. But what they found out in the lower doses, even though it is efficacious in the short-term pain control, it has got certain psychoperceptual adverse effects. So to add on, some adjunct drugs are tricyclic antidepressants, which includes nortriptyline, SNRIs like duloxetine, which should be avoided in hepatic impairment as well as heavy alcohol intake, and anti-epileptics like gabapentin and pregabalin in neuropathic pain. And other topical therapy, as we know, NSAIDs like nocaine, capsaicin. So these are the adjuvant drugs. So as Dr. Hanif discussed, there's a BEERS criteria. Now the American Geriatric Society has, in March, they have published the recent update. The previous was in 2019. So always, if you are working in an ED and you're going to see a large population of geriatric patients, please go read this criteria. And there are very common combination of drugs which should not be using, and or rather you should be very careful while using. So one of the relevant which I found was regarding opioids and benzodiazepine. And opioids and gabapentin, pregabalin, which is a very common combination which can be used but should be used very carefully, or rather used with adequate or reduced doses. Another option, instead of giving analgesic, you can consider regional minimal invasive therapy, as we discussed in the WHO LADAP. So nerve blocks like perineural blocks, neuroaxial techniques can also be done instead of giving IV or other route of analgesia. So take home would be, to overcome barriers of effective treatment of pain, we need to proper pain assessment. Pain assessment using pain assessment tools, consider multiple comorbid condition, and also the changing physiology or altered physiology as well as polypharmacy. A multimodal analgesic approach with non-opioids and regional techniques should be sought, and always start with lower doses and titrate in case of elderly patients. And also consider non-pharmacological therapies along with your pharmacological therapies. So these are the references. Thank you. Any questions?
Thank you, Dr. Rahul. Now the session is open for question. You can ask questions from the previous sessions also. Thank you. Thank you for all.
A very good evening to everyone who's still here. Thank you so much for being such a good audience. And thanks to the translators who's actually making this possible. Now we'll have our toxicological symposium. I am Siju V. Abraham, and with me I have Linu Shekhar. And we'll start. I just realized I was the first speaker.
So the first speaker would be Siju himself, and he is going to present to you a revolutionary finding which can make many of our lives easy for people who deal with snake bites. Probably if you listen properly, you can cut down on your costs and financial commitments involved in diagnostics. So be awake.
Oh, no. Thank you, Linu. And I think I'll just start. So, cloud waveform analysis, that's what I'm going to talk to you about. So when I came for the earlier session today morning, that's when I realized that most of my people here are medical residents, students. So instead of just bombarding you with what cloud waveform analysis in snakebite looks like, I want to actually start by saying a show of hands. How many of you have heard of cloud waveform analysis? Just a show of hands. Okay, so I got, yeah. Okay, I got just 4 hands up there. So let me put it this way. Cloud waveform analysis is what I'm going to talk to you about right now, and I've got a few financial disclosures. One, the results of the study which I'm going to present right now is actually funded by Indian Council for Medical Research. And this is the disclaimer from my institute. And I'll go directly into it. I want to introduce to you cloud waveform analysis. As Dr. Linu was gracious enough to say, I have this tool which came out of necessity for me. Because when we were taking care of snake bites, so I would like to look at TEG, I would like to look at Rotem. We do have Rotem, but Rotem costs maybe 3,000 rupees, which is approximately divided by 3 is what in lira. So if you look at it, it's actually quite expensive for anyone in our part of the world to actually afford. And the people who get bitten by snake is almost always the lowest strata of the society. So looking for stuff which can actually make a difference is when I came across this particular parameter, and probably it would be useful for you also. So first, I'd like to introduce you to this unexplored parameter. 2, I would like to tell you about our work on snake bite. And 3, if you guys go back to your institute, I want you to know if you have this there. I'm pretty sure, how many of you have APTT being done in your institute? APTT, activated partial thromboplastin time. Activated partial thromboplastin time. So I'm pretty sure you guys all have CWA in your department. Only difference is we do not know how to interpret the results. You know why I decided to actually look at it? Because the hematologists in my department, my institute, did not know how to interpret the results. That's the reason why I decided to look at it. Like David Carr was mentioning yesterday, being curious. That's the reason why I came across this parameter. So let me give you a brief history about what cloud waveform looks like. See, you have this coagulation cascade being explained in the initial phase by Paul Morowitz in 1905, I guess. And he gave you this cascading pathway, but it couldn't help explain much of the hemophiliac, how does the hemophiliacs bleed, etc. Then came the enzymatic pathway, where you did not know, say, why factor 13 or factor 12 bled, deficiency bled. And then came the modified coagulation cascade. Now, I'm pretty sure you guys are familiar with this one, because this is what most of our text actually tells you, right? What the coagulation cascade looks like. Now, it might come as a surprise to some of you that this is not exactly what happens in the body. Physiologically, it's actually much more complicated than what I just showed. The intrinsic and extrinsic pathway, it doesn't get compartmentalized like that. It actually starts with the subendothelial tissue being opened up, you having the tissue factor being exposed, and you having, you know, your volume-blood fraction factors attracting the platelets, you having the intrinsic, extrinsic TNAs being formed, you have the two-ways gathering and forming the intrinsic TNAs. So it initiates, it amplifies, and then the clot starts propagating. That's essentially what coagulation cascade looks like. But the problem is, to test all this, what you have is your PT and APTT. You have your prothrombin time, you have your activated partial thromboplastin time. Now, it does look at parts of the coagulation cascade, but it doesn't give you a holistic view. What if I were to tell you that even when you're doing it, you can actually see what's happening in the coagulation cascade? I'll explain it again. Because when you're doing a APTT, this is how you do it manually. You get the serum separated, you add activated partial thromboplastin. So what you do is you look at it, you add phospholipids, calcium, partial thromboplastin, and there's a color change, and you say there's the time taken for the color change. That's what you're looking at when you're doing it manually. Now, once people wanted to do it in an automated environment, once the machines came into play, they had to tell the machines how to see that. So what they did was, the same phenomenon: light source, activated partial thromboplastin time, change in color, but using nephrometry or transmittance or absorbance, you start getting, so this is an absorbance waveform. What it tells you is, if you look here, you can see the milliabsorbance, and here you have the time frame. So as time goes, the coagulation, the color of the plasma changes, and you have a coagulation change in the absorbance. And this is the clot waveform, or the fibrin clot waveform. So this is what is telling the machine that there is an APTT. Now, what is APTT? The point at which there is a maximum slope, or there are two different derivatives which is actually derived from it. So this is the velocity of the curve, and this is the acceleration of the curve. The pink one is the first derivative, or the velocity, and the blue one is the acceleration of the curve. Now, you have both of those happening there, and the peak of the second derivative is your APTT. Now, when you get your results, this is the only thing that you're looking at. You're missing all the other data. You're looking at this particular point where you have the maximum of the peak of the acceleration. So that's where the key lies. There's so much data which is not being used. Essentially what you're looking at is the pre-coagulation phase, the coagulation phase, and the stabilization phase of the APTT. That's what you're seeing when you're looking at this graph. And these are the extra parameters which were described. One is maximum time, maximum velocity, maximum acceleration, minimum acceleration, and delta absorbance. Let me get rid of all those nuances, terminologies, but I want you to know that this is there in all your APTTs, and you're only looking at this particular value there. Now, the drawback is, even though all your machines are making use of it, only a few of them actually display it as a curve or a graph. I've just listed out a few from an article from Shima et al. So that's a basic of what clot waveform is. Now let me tell you about our work on snakebite. So I started working on snakebite because I had no other option. We get all kinds of snakes brought to a ER. We get all kinds of snake brought to a ER, and we get all kinds of manifestations with regards to snakebite happening in our ER. So we treat around 900. So last year it was 964 snake bites. And we treat one. So it's like one requiring antivenom every 2 days. So it's kind of a large number, and we have this luxury of having all the snake bites brought to us. So I looked at the clot waveform analysis in specifically Russell's viper bite victims, and this is where we had the first major breakthrough, where you could see here all the APTT values except the last one was normal, but the clot waveform from the ones which I've been showing you were abnormal. Now that kind of triggered our interest, and that's when we started working on it more. We registered a study called waveform analysis in snake bite with hematotoxicity wish as a trial, and now we are in a position to actually propose 3 different uses for clot waveform in snake bite. 1, to detect envenomation. 2, to detect species-specific changes. And 3, to detect response to antivenom. I'll go through each one of them. 1, picking up early presentations. You know, we are in a state where we get people, unlike the common thought process, we don't have late presentations. We have people who come to us quite early because of the awareness in our community. We got people coming to us with snakebite early. Now, say this is a case of a lady who was brought in at 5:30 p.m. and 7:10 p.m. and she reached the ED at 7:10. 5:30 was a bite time, and that's a Russell's viper, which is a hematotoxic snake in our part of the world. And that's the initial APTT. APTT is actually quite normal, 28. But if you look closely, you can actually see there's a slur in the second derivative. Now the patient had local signs and symptoms, but coagulopathy hadn't developed. Now, in a situation where we have to wait for the coagulopathy to develop, for instance, snake bites, you don't have venom detection kits in most parts of the world, including ours. So we have a polyvalent antivenom, and to give antivenom, we have to look if that particular patient is having some sort of an envenomation change. And this actually shows you that. Now I'll tell you why I'm more excited, because once you give the antivenom, the coagulation, the clot waveform normalizes. I'll give you another example. So this is another case, bite time 8, brought to a test 9, 1 hour's time. That's the initial waveform. If you look closely, there's this part of the waveform is missing, means that it's prothrombotic in the initial phase. It's initially prothrombotic, then becomes coagulopathic. So that's missing, and post antivenom you can see that has corrected. I'll give you another example. Now, what about the other parts of India, you know, where people get brought to the ER quite late? By the way, all these are Russell's viper bite. I had the luxury of actually compiling only the Russell's viper bite for this particular session. So here it's completely, there's no APTT value, means APTT is more than 180 seconds, more than 360 seconds in this case. You don't have an APTT value. The patient was brought after 6 hours of bite, profound coagulopathy, but after giving antivenom, 6 hours after antivenom, you can see that the waveform has started developing. The APTT is still prolonged, and 12 hours after antivenom, it's kind of starting to normalize. So it shows, the second point, it shows response to antivenom. Now this is the breakthrough which I think we made, because you have someone with, so this is a control APTT clot waveform, and this is after adding dilute Russell's viper venom in vitro. And this is what the curve looks like in a patient with Russell's viper bite. It mimics the same. You have dilute Russell's viper venom added in vitro, and it looks the same as what you see in a Russell's viper bite. So we propose this particular fact as an experimental data that it can probably be a marker for detecting envenomation, species-specific changes. We haven't looked into it in much. We are right now looking at hump-nosed pit vipers and cobras, but soon we'll have a data. So, and for all those who are sitting here who's not interested in toxicology, so I'm going to actually give you potential application for CW in other conditions. See, CW came out in the picture when it was initially described, maybe in 2009 by Toe et al. And it bordered on to becoming one of the most sensitive and specific parameters to detect DIC in sepsis patients. And it was almost about to become a recommendation by the British Society. And with high specificity of 97.6 and 98% to detect intravascular coagulation sepsis. So a particular change in the waveform called a biphasic waveform. Later, people started experimenting with it in Claude waveform in hemophiliacs. You have multiple papers showing in hemophiliacs it as a useful parameter. And when you look at utility of Claude waveform coagulopathy, in the last few years, 2021, 27, something changed. COVID-19. And with COVID-19, people started describing so many more with regards to, I'll just point out a few. So this is a study which was done by Tan et al. In 2023, I guess, 2020, that's when it was published. So I'm not sure if you can actually read it. Bacteremia, dengue, viral fever, and that's control. There is a statistically significant difference, p-value less than 0.001 between. So it helps, in other words, it helps in distinguishing between different kinds of infections. So CW has been proposed as a parameter which can be considered to distinguish across bacteremia, dengue, viral fevers with relatively good sensitivity. Now in coagulopathy, in COVID-19, there's been multiple waveforms which has been described, and experimentally recently in thromboembolism, it has been shown that the values which I earlier mentioned, the min 1, min 2, the max 1, delta change has a significant difference amongst patients and controls. So in summary, CW remains an unexplored parameter, and in snake bite specifically, detection of envenomation, species-specific changes, detection of response to antivenom are things which you can consider, and research potential is still there. Anyone who's here who's actually got, so I want you to go back, find out if you have CW in your system. It can actually probably cut your cost a bit, or maybe at least as an experimental parameter for research purpose. Thank you so much for listening.
Thank you, Dr. Siju, for that wonderful talk. So, do we have any questions? So the next speaker would be Sari Sogan on chemical leaks and toxic effects.
Hi, everybody. My name's Sari, and I want to apologize in advance. I think I have a little bit of a cold, so my voice is awkward. So I'm going to be talking to you about chemical leaks and toxic effects, taking you in a completely different direction, but back to a topic that we started in the toxicology session in Hall B this morning, where we started talking a little bit about some of the toxicologic risks associated with major environmental disasters and kind of what to be prepared about. So chemical leaks are in that category, and I think the next few sessions are going to cover a little bit of preparedness with regard to these issues. I'm not advancing. Okay, a little bit about me. I'm an associate professor of emergency medicine and also a medical toxicologist. I work in New York at Bellevue Hospital and also at the New York City Poison Control Center. I do not have any financial or other interest to disclose. And I think in the next 15 minutes, we'll be talking a little bit about specifically chemicals involved in common industrial accidents. I read a recent review of chemicals that was published in the last year, stating that at this point there are some over 350,000 distinct chemical entities that are recognized from a regulatory perspective. Now, by all means, from the standpoint of human physiology and how we interact with these chemicals, there's a tremendous amount of overlap, and the number is not that great. But in trying to put together this talk, I really had to think about how to narrow it down. So I asked, what are the most common agents released in chemical disasters specifically? And wanted to give a couple of examples, not to know in any kind of exhaustive sense what each of these chemicals entails and what they do in the human body, but just some general principles, using a few examples to think through what's most common and what we need to know to be oriented in the emergency department to help manage these cases. So this was an interesting website that I found also just in preparation for this talk. It's a relatively new group that started during the pandemic, trying to bring some political awareness to the problem of chemical disasters and releases. And they put together, a group of people got together and put together a lobbying platform and a website with an interactive map where they were able to locate every chemical explosion or release happening in the United States by virtue of combing through media reports, websites, government releases, and so forth. And what they realized was that there is a chemical incident happening in the United States alone pretty much every other day. And that number is increasing. Now, there isn't data sufficient to understand what this looks like on a worldwide basis. That has not yet been compiled. And to understand the reasons why this might be increasing is completely speculative. But the WHO has been turning our attention for some time. This was a report, a book that was published in 2018, looking at the problem of what are called NATEC events, or chemical releases and chemical disasters that follow in the wake of natural disasters. So these are your earthquakes, your cyclones, and hurricanes, flooding and so forth, which are going to put infrastructure at risk and by all means lead to chemical releases and disasters and are actually require a more complicated response, since by virtue of the natural disaster, the health system would already be at risk. So this is a paper that I came across some years ago. It's probably out of date by now, but in just kind of looking through that website that I mentioned before, it seems like it might still hold true. That chemical incidents, you can see here on the right, this is the top 15 out of top 25 chemical incidents that happen in the United States during a multi-year period. You can see that pretty much every sector is involved, right? So it's not just chemical manufacturing, it's agric, it's water quality and sanitation, it's animal husbandry. So these are all sectors of society that would be much more widespread and available anywhere in the world. And you can see that the number of chemicals used and the number of incidents that are involved seems to be pretty widespread. And in terms of specific chemical agents involved, this is again the top 15 out of the top 25. You can see that with the exception of some hydrocarbons here and there, butane is there, propane is there, flammable mixture is there as number 3. The vast majority of these agents all fall into one general category. They're all pretty much irritant gases. So if you were going to try to get prepared, in the last session someone made the comments that most emergency physicians don't have the bandwidth to learn about and to remember every single chemical that's out there. By all means, most toxicologists don't have the bandwidth to learn all 350,000 different entities and what they might do. Absolutely no problem. If you were going to think about one high-yield toxidrome to get prepared on, it would be this irritant gas toxidrome. And these are a group of chemicals much larger than the ones we saw in that initial list and much larger than the examples I'm going to go through right now, but that all basically dissolve in the water within our mucous membranes and respiratory tract to form caustics and create direct tissue injury as a result. So you see here, I've made a little scale of more soluble to less soluble, and that's important in terms of thinking about how we might experience these toxic effects and in what time frame. So number 1 on that list, the most common chemical involved in these big disasters or releases, is ammonia. And most of us might have a frame of reference for pneumonia, or ammonia, not pneumonia, though it does cause pneumonia, as something we've encountered in smelling salts. I don't think those are all that ubiquitous now, but certainly when I was in training, we still had them around, these ampules of ammonia that you could break and hold under a patient's nose, and it would be immediately noxious. And most of you can remember what that felt like. So ammonia is something that is highly water soluble and will dissolve in your mucosa, your conjunctiva, your eyes, your upper airway quite immediately to form that noxious effect. And that's kind of protective because you can know to get away with it, from it. The other protective thing is that it's lighter than air, so it tends to disperse. If a big tanker like this were to explode, most of that would go up into the atmosphere and not settle on the ground. By contrast, chlorine tends to be a little bit heavier and to settle where we would breathe it in. That's also something that most of us can relate to as being relatively noxious from our experiences in swimming pools that might have been over-chlorinated and cause us to have stinging eyes and some chest heaviness. This is somewhat less soluble in water, however, and so it dissociates more slowly, and some of us, again, can relate to that we keep swimming despite the pain, and it's only later at night that our eyes are truly tearing and our lungs feel so terrible. So you could conceptually get a bigger dose and hang around longer within a chlorine cloud should a tanker like this explode in one's vicinity. Along those lines, I want to mention phosgene, which itself is not something that we would experience as being noxious all that much immediately. This takes quite a bit longer to dissolve, forming hypochlorous and hydrochloric acid within the respiratory tract. And the detectable limit is about 4 times higher than the upper limit of or upper threshold for toxicity. According to, I've never smelled it myself, but according to these World War I posters where it was used as a chemical warfare agent, it smells like fresh mown hay or like grass, something sweet, and not something that one would immediately want to run from. Again, increasing the risk that one could get a fairly decent dose before removing oneself from the gas. I don't know how many of you clued into what was happening during Fashion Week in Paris this year. There was a huge bed bug infestation in Paris that apparently is ongoing. And as a result, people were spraying a lot of chemicals to try to decontaminate these rooms and kill the bed bugs. I don't know if anybody knows what that agent is that is most commonly used for purpose, but it's sulfuryl fluoride. And this is a bit of an exception to the general irritant gas toxidrome that the other 3 agents I've just spoken about would produce. Sulfuryl fluoride doesn't so much, it does slowly hydrolyze in in the water of our mucosa and respiratory tract to form hydrofluoric acid. But more readily than that, it will simply dissociate to create a fluoride ion, which is highly reactive, an anion that reacts with calcium more so than magnesium and potassium, producing this toxidrome, the mnemonic for which is CATS, referring to convulsions, dysrhythmias. We can see here the classic signs of hypocalcemia, tetany, and so forth. And hydrogen sulfide is the last one that I want to mention as being a real exception. Yes, it absolutely is a respiratory irritant, an irritant gas, but its effects at higher doses or prolonged doses go far beyond the keratoconjunctivitis and the chemical pneumonitis that we might associate with lower doses of this and with the other irritant gases. And this by virtue of its ability to bind to cytochrome oxidases within the mitochondrial membrane and shut down ATP synthesis, creating a high anion lactic acidosis, which is a fundamentally different thing, looks a bit more like cyanide toxicity than an irritant gas toxidrome at higher levels. For this reason, it's been named the slaughterhouse sledgehammer, meaning that if it builds up within a space and someone were to walk into that space, it can cause an almost immediate knockdown, much like cyanide would cause almost immediate coma and shock. So our approach to management really today doesn't differ all that much from what it was or what was elaborated in the First World War as a result of many medics having to deal with high volumes of soldiers being exposed to chemical warfare agents. And back then, the standard of care was to follow the same principles that we use today, which is decontamination, decontamination, and then supportive care. So back then, decontamination looked a lot like using gauze soaked with water or saline to keep the eyes moist, and to have people gargle every 3 hours per this kernel. Today we might be a little bit fancier about that irrigation. There are eye wash stations. We can provide people with humidified oxygen and again have them gargle and so forth. In my ER, when I get these people who come in having been exposed to an irritant gas, I'll frequently hook up a nasal cannula to a bag of normal saline and lie them down with their head in a trash bag, and then do continuous irrigation via the nasal cannula placed just here at the top of their nose. Tell them to hold their eyes open and let it just, irrigate, irrigate, irrigate. Bronchodilators may be important. People will frequently be wheezing. And then the role of steroids is something that you'll see a lot in case reports, but is quite a bit more controversial. If you had somebody with like an ammonia exposure or someone who had significant upper airway swelling and edema, I think I probably would recommend steroids. But their role to prophylax and to prevent the development of long-term sequelae, pulmonary fibrosis and so forth, after a significant irritant assault is much more controversial. And in most review articles that have examined what evidence we do have, mostly from single case reports and case series, as well as animal studies, there hasn't consistently been, no benefit has consistently been found. I know in toxicology we love to talk about antidotes. They're certainly the most fun aspects of therapy. In this case, there are not too many that would be helpful, with one exception, maybe with hydrogen sulfide, which again, as I said, acts a little bit like cyanide poisoning. One could think about it conceptually as being the same. And the therapy here would be to administer nitrite therapy, similar to how you would do that in cyanide poisoning, and to try to induce a methemoglobinemia that might pull that hydrogen sulfide molecule off of the cytochrome oxidase and help detoxify it. There's been some work, mostly with animal studies, looking at an analog to B12, much like we have hydroxycobalamin now being used for cyanide poisoning. That one doesn't seem to work as well for hydrogen sulfide, but this one, cobinamide, has quite great affinity for the molecule, and at least in these animal models, has been shown to be quite helpful in pulling it off and detoxifying it. I guess another exception might be many of you might have heard of giving nebulized bicarbonate, and that's specifically in cases of chlorine ingestion. It hasn't been shown to be all that helpful in other chemical entities, and certainly not been well studied in many human models, but we do have some small evidence in chlorine that it may shorten the duration of symptoms and help people feel better faster. So I want to just end with a brief remark on the long-term effects of these chemical exposures and this kind of subacute management. I haven't focused too much on the history of major incidents, but I feel it would be remiss not to talk about Bhopal, which is both the largest chemical disaster that we've experienced in the last century, I guess. And something where we now have 40 years of experience seeing what happens to people in the aftermath of the event. In this case, an irritant gas, again, was released in massive quantity after an explosion at a factory in 1984. And within about the first 5 days, officially 3,800 people died of this irritant gas exposure and toxidrome that I've been talking about. At the 30-year mark, however, the government officially recognized almost 600,000 people who had been affected and who continued to show the effects at 30 years, including a high incidence of birth defects and of cancers, anywhere from 8 to 27 times increased risk associated with this, as well as significant sequelae from long-term inflammatory changes in the eyes, in the corneal opacification, for example, and in the lungs, both bronchiolitis obliterans and pulmonary fibrosis developing kind of 30 and 40 years out. People are still suffering from this. So I wanted to end with just this note that the good physician treats the disease, and I think as emergency physicians, we all have the advanced life support skills to do a great job in the vast majority of these cases without much specialized knowledge of what specifically the chemical was and how to treat it from a toxicologic standpoint. But the great physician treats the patient who has the disease, and in many of these cases, people are going to want to know not just, how can I feel better right now, but am I going to be okay down the road? And in that case, knowing what actually was released and being able to say something specific about the long-term consequences can be extraordinarily reassuring to people and an important part of what we do. So with that, I'm going to end and hand over to the next speaker, who I think will talk more about how one might go about finding out which agent was released.
Thank you, Sari. And we have Sage coming next, and Dr. Sage is going to talk about the prevention and protection measures in the community level.
Okay, so I'm going to talk about what we can do to protect our communities from these kinds of disasters. Brief slide about my background. I'm also a toxicologist who works in New York City. I work in Brooklyn, and I have no conflicts of interest to disclose. So I'm going to go over some background about preparation for chemical releases. Talk about how we can identify some of the potential threats, whether they're industrial, whether they're used for malicious purposes, and then how we can prepare, what equipment we might need, how we can prepare about decontamination, how we can get information when we do identify a toxin, and then how we can address the availability of antidotes. So there are a number of ways that chemicals can be released. It can be intentional, it can be unintentional. Some sources include natural disasters, industrial accidents, transportation of chemicals, terrorism, and chemical warfare. And it's important to recognize that to some extent there's a bit of artificiality of this, because while it's true that people who have malicious intent with release of a chemical, there's a lot of agents that have been developed specifically for that purpose. But if if it may not be necessary for somebody to have the ability to synthesize a chemical, if they can identify a dangerous substance that's used in large quantities in your community, they could attack that source of the chemical that's already sitting there and potentially cause a release that can cause damage. So I'm just going to review some examples of some of these. This is an example from Cameroon, where there's a lake in the bottom of a valley that contains a lot of rock that contains carbon dioxide. And one day, the lake essentially burped up a big cloud of carbon dioxide, and that acted as an asphyxiant that killed a lot of people and livestock that were living in that valley. Here in Turkey, there was a release just a year ago of cyanide from a mine into a lake. So that, there are industrial sources, and Dr. Sari did a great job of reviewing how ubiquitous all of the different potential industrial sources are, and it cuts across a lot of things that we don't necessarily think of as sources of chemical releases. This is one that happened this year in the U.S. in Ohio. A train derailed that was carrying phosgene and hydrochloric acid, and also led to release of vinyl chloride. And this is a tough one to address, because we can identify the chemicals that might be being used in our community and prepare for those, but then how do you prepare for chemicals that just happen to be passing through your community and are released because of an accident like this? This is from the sarin attack on the Tokyo subway, so this is an example of an actual chemical weapon that was used. And another example of state-level chemical warfare. This is in Syria, and you can see that in the explosion here, the gas release, that green color indicated the presence of chlorine gas. So these are all different potential ways that people could become exposed to a chemical in large numbers. And to just highlight the difference between a chemical attack compared to a biological and a radiological attack, the biggest difference is the time frame, right? People who are exposed to chemicals, typically, for most chemicals, and obviously there are exceptions for things like phosgene, but most things tend to have fairly rapid effects, and you need to recognize that, and that's really important in terms of personal protective equipment and decontamination that take a much higher priority compared to biological attacks and radiological attacks, because it's very easy for the person who's taking care of these patients to become a patient themselves if we're not addressing those things carefully. Now, when we see critically ill patients, I think we generally know what to do with those, but the problem is that there are so many worried well, right? The critically ill patient is the tip of the iceberg. They're going to be and a good example is the sarin attack on the Tokyo subway, right? There were about, I think, 688 patients that were transported by ambulance to hospitals after that exposure. 5,000 people presented to hospitals on their own that just transported themselves. There were 1,000 people that had some type of cholinergic effect. I think about 30-something that were significantly ill, and 8 fatalities. So you can see for every really critically injured person, there's a ton of worried well, and we have to think about preparing for what to do with those people when they present to your hospital, and specifically allocating specific space for those people, and have a plan for that. And also to control access to your hospital so you don't have people who have not been decontaminated coming and contaminating the clinical area that you're going to need to take care of these patients. And that kind of tip of the iceberg idea is really just an expression of the dose response curve, right? And that comes from Paracelsus, who said, what is there that is not a poison? All things are poison and nothing is without poison. It is only the dose that makes a thing not a poison. So people who are exposed to a lot are going to be critically ill, but there's going to be a lot more people who are exposed to a little and might have minor effects, and you really need to sort them out. So in terms of identifying the potential threats that we might be seeing, thinking about the different industrial pollutants that might be used in your community, is going to be important, and preparing specifically for those. And Dr. Sari made an excellent point that in general, preparing for pulmonary irritants and asphyxiants is really going to deal with the large majority of these, but there are other threats that are out there. And in terms of preparing, what can you do? Well, we mentioned PPE, and there's going to be a lecture following me that is going to specifically address that, so I'm not going to go into too much detail about that. Preparing for decontamination, both in the field at the scene, at the site of the release, as well as at the hospital for patients who may not have been transported by ambulance from that site. We'll look at how we get information both to the community and for ourselves as healthcare professionals, and then what we can do to address specific antidotes when there is a release of something that does have an antidote. So here's an example of making sure that you have appropriate PPE for your first responders and for your staff in the hospital. Having appropriate equipment to be able to decontaminate people at the scene. Ideally, you don't want to transport contaminated patients in your ambulance because it's going to contaminate the ambulance and take it out of circulation, right? So you ideally want to transport people after they've been decontaminated at the scene. But at the same time, if you're working at the hospital and receiving these patients, you cannot assume that that has been done appropriately. So you have to treat every patient as they are potentially contaminated. And that's really going to mean controlling access at your hospital and making sure that patients are decontaminated before they're brought in. This is an example of our decontamination facilities at one of my hospitals at SUNY Downstate. And when we think about decontamination, you're going to need to separate your hot zone, where you have your contaminated patients, your warm zone, and that has that decon corridor, and ultimately the cold zone, where you're going to go on to treatment. And remember, this is where your chemical exposures are different from nuclear and biological, because decon takes priority over resuscitation, because that chemical is potentially going to kill them and potentially be a threat to you before they die of other things. In terms of getting information, getting chemical fact sheets for the community can be helpful, and a lot of them are online. In the US, we have the CDC and ATSDR, our agencies that produce some of these chemical fact sheets. For healthcare providers, the MSDS, or Material Safety Data Sheet, is going to be a valuable resource, and I'm going to give you an example of how that can be useful. And then, does anyone here have the Wiser app on your smartphone? It's very useful for identifying hazardous materials that are being transported through your community. If you've ever noticed on trucks or trains that are carrying chemicals, there are certain types of a code that basically tells you what's being carried, and that it can help you rapidly identify what's being used. So this is just an example of the CDC website, some examples of fact sheets that are available that are in language for lay people, that will let them understand what the potential risks are, what they should do if they may have been exposed. And ATSDR is another agency that puts out similar information. This is a picture. I was sitting with my wife in Istanbul the other day and having a delicious lunch of fish durum, and I looked across the street and I saw these chemicals there. I said, that's interesting. That's right near where I'm eating. And so how would I get information about those things if I wanted to look up what the potential effects are? So I can go to Google and I can type in acetone and MSDS. Remember, MSDS is Material Safety Data Sheet. And I'll get a bunch of different sources for material safety data sheets. Now, these were originally developed for industrial purposes. So in the US, any chemical that's potentially hazardous that's being used in the workplace, they have to have the MSDS for that chemical on site. But now these are all online, and you can look them up for basically anything. And they're not just for chemical names, but also brand names of products will have the MSDS associated with them. And it has a ton of information, physical properties, what potential hazards that they pose, what to do for first aid, what to do for firefighters if there's combustion of these agents. So a ton of information with a quick Google search that's available. This is a 10-sheet document just for acetone as an example. This is an example of the hazmat symbols that are used when a chemical is being transported in the US. And so we can use these symbols to identify what potential threats, if there's a spill, if there's a train that derails, or if there's a collision of another type of vehicle that's carrying chemicals. And the Wiser app, which is soon to be replaced by the ERDSS app, is really useful. It's something that you can download for free. It allows you to browse if you know what substance is involved, but if you don't know what substance, you can use the codes and it'll help you identify what the substance might be or what class of substances might be involved. The next thing I want to address is antidotes. And again, most of the things, as Dr. Sari mentioned, is really about removal from exposure, decontamination, and supportive care. But there are a few things that have antidotes, and there are guidelines for what antidotes should be stockpiled for hospitals. This is an example of a consensus guideline for the United States, at least, about what things should be stocked. And this is the New Mexico Poison Center has put how they have interpreted that and what they stock in their hospital. And obviously this needs to be tailored to each community. If you have different potential threats that are involved, then you may have to adjust that to some extent. And you want to prepare for mass casualty situations by having a pharmacy disaster cart so that you'll have an easy way to get a large amount of needed material to where it's needed within the hospital if you have a large amount of patients presenting at once. And on a larger scale, thinking at the government level in terms of strategic national stockpiles, in the U.S. we have what's called push packages of antidote and equipment, about 50 tons of material in each of these push packets, and it's enough to fill the belly of a wide-body cargo jet. This is a picture, and you can see there are a number of carts, and they're designed to fit exactly into the space in the cargo jet. And you can get a large amount of material to where it's needed within a few hours, and they're at strategic locations around the United States for when they're needed. This was first created in 1999 by President Clinton at that time in response to a number of chemical events at that time, the first World Trade Center bombing, the sarin attack on the Tokyo subway, and the Oklahoma City bombing. And initially it was just for CBRNE threats, but now it's been expanded to other types of threats, and they have 2,000 caches of nerve agent antidotes known as chempacks that are strategically placed around the country separately from the other types of push packets. So just to recap, think about the different potential ways that you might have a release. Think about how we can identify the potential threats, both industrial, and think about how those potentially could be used by people with malicious intent. Prepare in terms of your equipment that's available, in terms of thinking about decontamination procedures ahead of time before you need them, how you're going to deal with those worried well, and how you're going to control access points within your hospital to prevent people who are presenting on their own from getting, who have not yet been decontaminated, from getting into your clinical area, how you're going to get information to the community and to healthcare providers, and think about your antidotes. Are there any questions? All right, thank you.
Thank you, Sage, for this comprehensive overview of prevention and protection measures in the community level. Now, we have Dr. Linu Shekhar talking about the prevention and protection measure on a personal level. This will be the last talk for the session. And the last speaker, which was given as Ashish Bhalla, has already taken a session in the toxicology session earlier. So, Linu Shekhar, prevention and protection measures, personal protection. As the speaker is setting up, if there are any questions which you want to address to the prior speakers. Everyone's having a stretch. That should be good. Now, we'll have Linu back on stage. Linu. In which case, I have a question. Can I have the mic to one of the... So, the question is to Dr. Sage. With regards to, so we decided to actually have an antidote bank in our place. Now, our biggest problem was the expiry date on these and the cost of maintaining it. So, for us a cost, say, underdeveloped nation, do you have any suggestion as to how we can actually start one on a smaller scale with regards to what should be stored? Say for the Cyanokit, it's 5 lakhs Indian rupee to actually store 1 vial of it, and we get. So, is the mic available? I think you can take this thing. Yes, sir.
Okay, so I think that the best way to address that is to continually rotate drug out of your disaster supplies into your regular use and replace the disaster supplies so that it's not had a chance to expire. I mean, that won't help for things that are used very rarely, but for things that are used commonly, you want to restock the disaster cart, move supplies from the disaster cart into your general use so that they're not sitting there and expiring is really your best approach.
And what about the expiry dates? You know, say methylene blue. Do they actually expire?
So that is another good point, and I think it depends on your situation, how much you have to pay attention to those expiry dates. Most drugs don't really expire. And there's pretty good data that certainly for things like tablets, they probably are good for years past their date. One of my colleagues at New York City Poison Control did a study where he looked at atropine from a World War II nerve agent antidote kit and found that 70 years later, it still had close to 90% of the original amount of drug in it. So, if you don't have the capacity to maintain those supplies within the suggested expiration dates, it's probably fine to use them. In my clinical setting, that's not considered acceptable outside of an emergency setting. But depending on your clinical scenario and your resources, it may be reasonable to use expired drug. And we do have precedent for that, even in the U.S. Some of our antivenins, when the Wyeth polyvalent antivenin that's used for crotalid envenomation was all expired, it stopped being produced, they were still making exceptions to allow it to be used after it was expired.
Thank you, Sage. And thank you for filling the gap when Linu was setting up. Thank you so much.
So, good evening. My job is to complete the gap that what you do for personal protection level in case of a hazmat event. And my job has been made much easy by 2 factors. One is our senior Dr. Sage has completed it very comprehensively, and another one would be the pandemic which we had just encountered, which has taught all of us how to do a proper donning and doffing of a personal protective equipment. So I don't have any financial interest to disclose. So disaster is considered as a hazard when it is more of a natural cause, something's beyond something called as force majeure. It's beyond the control of the humans, and it is considered to be a threat when it has got a more of a man-made character, like act of bioterrorism or such things. Be it hazard or be it threat, we need to cater ourselves accordingly so that the event is mitigated properly. So, depending upon what we are dealing with, we will have to change our strategy. But on a personal level, the first and foremost thing to be understood is that unless you have a healthy rescuer, a healthy doctor, a healthy paramedic, a healthy technician, there is no scope for the community who is at the face of the disaster. So before going into PPE levels, the protection levels, I just dwelled on to find whether there are any prevention or mitigation strategies so that there is increased efficiency in handling future events. So as we all know, as emergency physicians, training is the way to go. But apart from that, there are few legislation points which the administrative section with a good political will can handle. Firstly, it would involve improved methods and procedures for transporting hazardous materials and poisonous agents, promoting compliance with safety codes and regulations and status, many countries of which would have, many of the developing countries don't have the same. And there should be a plan so that hazardous chemicals are manufactured far from civilian areas. So those are few things which can probably mitigate or prevent future events. Increasing public and community awareness and support for the prevention. Because in most disasters and most hazmats, everybody is caught in the thick of things very soon. And however hard we train, it finds that whether it is a toxic gas leak or whether it is a bio threat, everybody attains only 50% of the training of the expected outcome. So we need more training courses like hazmat and more training for the emergency first responders in the first place, so that all these things, when put in place properly, helps in improving the efficiency of our management. So personal protective equipment is the main focus of personal protection, and how you engaged and how you effectively manage these events on a personal level. So the responders should be trained not only in the proper donning and doffing, they should also know what their equipment is going to handle, whether that equipment is sufficient to handle the toxic agent in place on first hand, whether how far can he or she compromise on the available thing, and how do you weigh the risks and benefits of what equipment is being used with. And lastly, how to dispose of this PPE should also be taught to the stakeholders. So now coming to one of the most important parts, which we learned, many countries learned during the COVID pandemic in a hard way, that if you don't don a PPE properly, then you are inviting trouble. Better off without a PPE. So it applies the same to toxic disasters as well. So there should be a separate area for donning and doffing. Ideally, they should be cordoned off in different places. And the doffing area should be designed in accordance with the biomedical waste guidelines policy of the concerned institution. So these are prerequisites. And what we should understand is that there are different types of PPE, and the different types, each type will have a separate instruction of its own, so that the purpose is served. The purpose is that the rescuer or the first responder is protected properly. For example, this I have taken from the COVID literature itself. An interventional radiology patient who goes to the IR suite, how does he, sorry, not a patient, a responder who goes to the IR suite at the time of everybody was afraid about COVID, at that time, how he goes and handles a COVID positive patient. So there, the steps have been shown here. So I'm not reading out all these things because it is different in each case. In here, if you see, after completely donning the PPE, he has to put on a lead apron also. So it depends upon what agent you are dealing with, the steps might have a different. But you have to be knowledgeable. That is the take-home point. Unless you are knowledgeable, there is no use having any fancy PPE with you. And this is again a picture of another, I took it from some other place here, whether how you properly doff the PPE. There will be different steps, and it usually starts with the part covering the head and it ends with the part covering the legs. It is if the doffing is also not done properly, it can also do more harm than your intended protection. You might be protected, but the PPE would be helping to disseminate this agent to others. So now coming to levels of protection, Environmental Protection Agency of the US defines 4 levels of protection for PPE, with the level A giving the greatest protection and level D giving the least one. So what is level A? It provides the highest level of both respiratory and skin protection. It protects the respiratory tract and mucous membranes and skin from all types of vapors as well. So this is airtight and fully encapsulating, and self-contained breathing apparatus which is accompanied will be within the suit. So nothing is left out of the patient. It is wholly encapsulating the patient, and it would be fully chemical and vapor protective suit, and it is suited for all toxins. And in addition, it would have outer chemical resistant gloves and boots as well. So this is the picture of a self-containing breathing apparatus, which you would see in case of most of the first responders. Coming to level B, it provides the highest level of respiratory protection and skin splash by using chemical resistant clothing. But it does not provide skin vapor protection, though it provides protection to the respiratory tract. So here the difference is that the self-contained breathing apparatus is not enclosed within the suit. It is coming as a separate unit, so it is not fully tight, and there will be some level of protection which is lost. So examples of level B protection would include the SCBA, or the self-contained breathing apparatus used in conjunction or separately, along with gloves and a face shield with some chemical resistant clothing and chemical resistant boots. And coming to level C, the level C protection should be used when the airborne xenobiotic is known, its concentration can be measured, and the toxin qualifies for use of air purifying respirators. And in addition, we don't think that there is a skin or eye exposure is present in such patients or in such toxins. So it protects splash protection as the same level as B, but a lower level of respiratory protection than classes A and B. Majority of the hospitals expect that their EMTs or the first responder team to have level C protection training. But that may not be the case in case of a toxic disaster. So these 3 are the actual levels, and there is a level D which is written theoretically, but it is not used because it is nothing more than a routine uniform or the scrubs which we use in our routine departments. It provides no respiratory protection and only minimal skin protection. And then why is there a level D? So this level D is that this should not be worn in case of toxic disasters. That's why it has been designed. So this gives a picture of level A, level B, and level C of PPEs. Here, as I discussed, you can see level A shows that the respirator device is also inside the suit. So it is a completely sealed issue. And level B would be the respirator would be outside your suit. So it gives a lesser amount of protection. And as you can see, level C, the eyes and the face are actually not covered, but there is a purifying respirator associated with the suit. So this is again just an extension of what Dr. Sage had discussed. All the treatment of the patient should actually happen only in the green zone. So the red and the hot and the warm zones are actually for extrication and for removing for decontamination of these patients. And so these PPEs are done appropriately in accordance to the area as well as the toxin in question. So this is just a summarizing of what level of protection is given by each type of PPE, and obviously the level A PPEs would be the best, which gives comprehensive protection against vapors, aerosols, for the eyes, skin, and the respiratory tract. So, with that, I end my talk here. If there are any questions regarding personal protection or donning or doffing techniques, I'm happy to take it.
Are there any questions from the audience? I'm pretty sure by the end of COVID kind of helped us understand what donning and doffing meant. You know, it brought that to everyone. So this was the last speaker for the night, and hope you all have a good night. See you all tomorrow. Good night. Thank you.
You can calculate the surface according with the weight. Total body superficie, weight, kilograms, and also for less and more than 10 kilograms. How you maintain the routine for the fluids? If the patient is more than 10 kilograms, you can increase 50 milliliters per kilo per day for the next 10 kilograms, or 20 per kilo per day if they are over 20 kilograms. So you need to be careful, because sometimes if you use more than this, you are overloaded. How is the balance between the income water? Is about the income oral water that you use them, and also performing water and oxidation water. And what is the expenses that you have? In sensitive losses like urine, stool, sweat, temperature, and breathing. So this is how you expense this. In this period, you have two different periods to treat the patient. The first one is the resuscitation phase in acute presentation, when the fluids is needed to restore adequate tissue perfusion and prevent the lesion. In this time is immediately, the next couple of minutes and the next hour. The second phase for the period is the tridatration phase. Is a critical window to determine what intravascular repletion has been achieved and the trajectory of the fluids gain versus losses. And the third phase, or the third period, is maintain the phase, is the moment in which the fluids must be supplied to achieve the precise hemostatic equilibrium between the needs and the losses the patient present. And the next phase is convalescence, the period in which the administration of exogenous fluids is stopped and the patient return for the intrinsic regulation of the fluids. So it's a break to invite you to come to the conference next November in Mexico. So be careful. A specific protocols dose is not able to apply for all patients. Every patient needs to be particular way to treatment. The needs of the fluids in patient ER is very widely. So many patients depend the pathology, depend the antecedent they have, because it's very different. So the choice of the appropriate type and amount of the volume require great care. So you need to be careful about that. This is why we use different type of the solution. We have crystalloids and also we have colloids. Colloids is the best expanding capacity given by the sodium and maintain the electrolyte balance. But you need to be careful. 80% of the volume of the solution go straight to the internal space. Between 20 and 25% stay intravascular space, and the next 15 minutes disappear. So you need to be careful about that, because when you start to overloading the doses of the solution, you produce more damage. So the colloids is try to maintain the colloids pressure, and is one of the best expander volume. So you can use other solutions like gelatin, dextran, or albumin. And you can see, if you compare the solution that the crystalloids, Ringer lactate, and you compare with the plasma, and you see the tonicity, and you see the equivalence between sodium and chlorine are similar. This is why we use most of the time this solution in the beginning of the patient. So also the osmolarity, if you compare with the plasma, The first one, the isotonic, is the osmolarity is osmolar and isotonic. But also, if you compare with the plasma, the next one, the tonicity is the same. So it's osmolar and isotonic for the patient that they use isotonic crystal contain between 121 milliequivalents of the sodium per solution. So what is the indication if we want to use the solution? In emergency room, normally we use a lot of physiology solution, and also we use the lactate ringer. So what is the indication for this is for reposition volume, hypovolemic shock, and also when you use lactate is for hypovolemic shock and reposition. The other one is the artificial colloids that we use for replacement volume, and also with the patient when present burns or ascites or nephropathy syndrome. You can see in this table what is the characteristic of the different states. The principal goal that you have in the first step, the rescue, is the life-saving and correct the shock. So the time that you need to use is minutes. And this is typical scenario for septic shock and major trauma and hypovolemic shock. The next is the optimization. The principal goal is rescue the organs, and also you can use for burns, ketoacidosis, and you can spend 4 hours, the next hours to use it. And the third line, this is the stabilization. The principal goal is the organ support. You can use in days and stable it, and also use for patients that they have pancreatitis or they have open wound or something. And the last is this escalation is for preserve the organ recovery. This is the principal goal. And this is the time that you see, you can use in days and the weeks, but also you can use it for patients that they are in the parenteral or they are in the other problems for the surgery and other things. So in these different states, you can see what is the principal goal in every state that you see to try to maintain the solution. So in resume, rescue is between 0 and 24 hours. Optimization is between 24 and 72 hours. Stabilization is 72 to 110, and desreanimation is after 110 hours. So you can see the strong recommendation accord with this chapter. This is one of the papers that they wrote in the last November, and this is other one in the last December. And they showed the guidelines to this, and they are the evidence to recommend the fluids, the use of the provide critical support for patients that they are really serious, and for that patient that they cannot provide or they do not use the enteral administration like gastroenteritis, respiratory problem, and the patient with neurology, right? So in these papers that I show you, they recommend the administration of the hypotonic solution has been the standard in pediatrics. But most of them, they have incident for the hyponatremia. So you need to be careful because the patient, when you start to use this solution, they produce more hyponatremia than the other ones. This is why in these papers and other more than this, they recommend the isotonic solution for children that they need IV solution could be prevent the development of the hyponatremia. So they don't use hypotonic, they now use isotonic because they want to prevent hyponatremia. In this paper also, they have a strong recommendation on the isotonic solution between the patient to 28 days until 18 years old, they require solution and should receive isotonic solution because with appropriate potassium chloride and dextrosa, they significantly reduce the risk of developing hyponatremia. So in that way, you can prevent more complications than the benefits that you can do. Also, you can use the personalized fluid resuscitation. Require principal attention for this pneumonic. Context, indication, target, timing, among the fluids, infusion strategy, a type of diffusion that you want to use in case the patient requires. So this model using characterization is for every patient in particular. This was published recently in 2015, and they are now accepted, and because they are not normally accepted for all people that work in the emergency room in pediatric situation. But over the years, emergency room, we create the shock units or trauma units, and they have developed over the years. One could argue that the PER has offered the ultimate environment to the real-time personal medicine. When we treat patients in the emergency room, and specifically in the bay of the trauma or burns or ketoacidosis, we personalize the treatment for every patient. So remember, in emergency medicine are significant heterogeneous, the patient. Sometimes they have one disease, sometimes they have problem for genetics, sometimes. So we need to personalize medicine for different patients that we receive. But also we have other problem, the problem with the sepsis. The treatment remains remarkably weak and highly conflicting. If you see, the diagnosis of sepsis require interpretation, no specific signs, and can therefore be subjective and variable. So this is why you need to pay attention, because the heterogeneity and intervention may be benefit for one group, but could be harmful for the other group when you have patients with the sepsis or more pathology. The future is that we need to focus on several important issues. First, we need to educate the clinician about the risk of the fluids loading patients who are not fluid respondent. The potential of the harm caused by the fluid bolus therapy should be more clearly featured in the guidelines. Other implementation is the physiology and a hemodynamic guide, conservative approach, the fluid therapy in patients with sepsis. Good possibility to reduce the morbidity and improve the outcome if you use correctly the fluids. The second is the effect of the fluids infusion in the immune system. On endothelial function, in the one integrity, the glycocalyx remain poorly understood. Degradation of the glycocalyx on the vascular luminal cell membrane has been identified to be early step for the sepsis, for the subvascular endothelial cell disorder. So if you see, when you start to use this in bolus, you can produce more damage than benefits for the patient, because start to destroy and more damage for the different part of the human body. So the second one is the fluid therapy has the potential to the further damage for the glycocalyx, especially when you have rapid infusion, as used when the fluid infusion results in hyperkalemia. So you have alternative fluids volume therapy for the treatment in shock that the early use and vasoactive drugs. So in that way you can prevent more damage for the kidney and also for them. And the third concept is the hypertonic resuscitation may provide effective and rapid intravascular bovine resuscitation for the patient in the emergency room. So in conclusion, there is no ideal solution that guarantees the correlation with electrolytes and normality, and it's important to individualize the liquor measure according with the physiology and the pathology of each patient that comes to the emergency room. So in London in 2013, they proposed 3 points. One is the goals, the fluid therapy for goals to every patient. The method of monitoring the patient in the emergency room and the different clinical contexts about this patient. So in conclusion, the fluid resuscitation has not been one of the cornerstones in the treatment. An increased body of literature suggests that the fluid volume therapy may contribute to the fluid overload and cause harm. The effect of the fluid bolus on physiological parameters are not well studied and seen small and short-lived and the best. Personal fluid administration requires clinicians to integrate abnormal physiology parameters into clinical decision-making. So personal fluid resuscitation therefore requires careful attention for each patient with the mnemonic name that I told you before: context, indication, target, time, amount, and everything, so and so. More of the progress that has been made in emergency medicine is the result of identifying and abandoning the potential harmful intervention in the treatment. So it's time, perhaps now, to add the indiscriminate use of the therapy for that list. Because sometimes when the patients come to the emergency room, it's like normally they order to, hey, they go glucosalin or they go glucose 5% and started this, and sometimes produce more hyponatremia or alteration in the electrolytes, and they produce more damage in the kidney or the perfusion in the cellular zone. So I think this is the new concept that they have now in the emergency room about the solution for the patient, pediatric patient in the ER. I don't know if you have a question. Question? Yes, sir.
Yeah.
Thank you very much, Professor Carlos, for your nice presentation. My question is about that. Do we have an ideal mean arterial pressure or systolic blood pressure to maintain an adequate organ perfusion or tissue oxygenation for the children while infusing the resuscitation?
That I show you in the score depend what is the situation of the patient. You can see for the first one is for the rescue. So you can use the isotonic solution to prevent the alteration of the hyponatremia. This is how you use in the patient in the ER. The paper that I show you, they show that if you still use it, glucose 5%, you can produce more alteration in the electrolytes like the sodium hyponatremia than it's better if you use isotonic solution in the patient.
Excellent. Excellent. I think we have one more question over there. Please go ahead.
Thank you for your presentation, Professor Garcia Rosas. In trauma surgery with major hemorrhage, contemporary best practice is damage control resuscitation with limited use of crystalloids and early use of blood components. That's for adults. What has been the experience of damage control resuscitation in children?
Well, first of all, if the patient they have really hemorrhagic shock severe, the best thing is use blood. If you have, but in trauma, sometimes you are not available the blood already, so you start with crystalloids to use them, and then when you have already the blood, you start to treat the patient with blood, because this is the recommendation that we have in the ER. The most important is recovery and control the damage for the patient in trauma. Trauma is a particular issue that is different like the other issues, right? Trauma, you need to be ready for number of the blood components and everything to try to control. And also, if they need a laparotomy to control the damage for the liver or for any injury inside, you need to control and start to use the blood.
My question was the difference between adults and children. What are the differences? Are there any?
For children, what age? Because the children is 28 to 18. If you're talking about teenagers, or what age, any age, at the beginning you start to use crystalloids. Then when you get it, the blood component, you use it. Because the point is, first of all, you need to control the bleeding. Depend what we're talking about, liver or whatever. But the second one is you start if you have the elements for the blood, you use blood or component of the blood, right? But if you don't have it at the beginning, you use crystalloids and for treat the hypovolemic shock. This is how we use it. I don't know if it's the answer or not.
Thank you. Thank you. I think that's a great answer to the question. There's very little difference. If you have blood, use it. And if you don't, try volume expansion with crystalloids until you do. Right? Are there any other questions? No? Okay. Thank you. I think with that, we'll move on to our next speaker.
Thank you.
Okay. Our next speaker is Dr. Başak Yılmaz. She is an emergency medicine physician and working in the State Hospital of Burdur, Turkey. And she's also the member of USM. Her topic is the indication of the CT in the emergency department. You are welcome.
So they gave me some room to move. Thank you for that, and sorry for my sore throat and a terrible voice. Bear with me. I'm an emergency physician, a fresh one, and all emergency physicians have their interest areas. And pediatric emergency medicine definitely is not one of mine. But it doesn't really matter if you're in emergency medicine, because well, all the emergency cases basically just show up at your door. You care for the pediatric patient or not, they will be there and you will need to take care of them. So you will need to know how to act. And the title I was given was to CT or not to CT. Well, to me, that's not the question. You know, when it comes to CTs, nothing's really all black or all white. The CTs work in grayscale. We have a lot of room in between. If you want to know all the criteria, all the guidelines, they're out in the world. You can go out, check them out. You don't even need to memorize them. There are a lot of applications right now. You can just check the criteria on my mobile phone when you see the patient. Do I need to CT them or not? But there are other sets of questions you need to ask before you try to make your mind. The first and the most basic one is, can we CT? Do we even have a CT machine? Are we in an established center blessed with a CT machine that we now take for granted during our training programs? We may be in a humanitarian aid area with a limited resource setting. We may be in a rural hospital. Our city might be out of order. That happens all the time. We might have a CT, but we may not have the skill set to evaluate the images we have. We might have the skill set to evaluate the images, but it may not be accepted as the official report by our governing bodies. So we may also need the report from the radiologist. Do we have access to a radiologist 24/7 in our centers? So do we need to refer our patients who we perform CTs on to an upper level center? So should we perform the CT? I work in a rural hospital, the only hospital in my small city, with a lot of connecting towns nearby. Two of my connecting towns have CT but they don't have the GP, they only have GPs on call, and they don't certainly have emergency physicians or radiologists that they can refer their CT images to during their shifts. So a lot of times I receive patients that have pan CTs performed, but they don't have the images. I can't retrieve the images to evaluate myself. I need to perform everything all over again. The patient gets twice the dose. After the evaluation, I see something, or most of the times, I don't see anything. I discharge the patient, and the patient has no means to go back home. And this is important. If asking for a CT, if to CT means hundreds of kilometers, if it comes on the expense of hours of lack of an inter-hospital or per-hospital transfer team, depending on how they operate in your home city, it really affects your practice, your day-to-day practice. So should we CT? Will it really change our practice? This is something we should consider. Is it a minor trauma that I can simply observe in my own center and decide if I want to refer it to the upper center later on or not? Or is it something that my surgeon can handle? For example, is it an, I don't know, stomach pain, a possible appendicitis? And can I operate without the CT? Should I really refer the patient to an upper center for that? How many of you work in an environment as sterile as that? Or is it more like this or this? This is how we work in Turkey. So we work in overpressured, overworked, overcrowded environments. So we always feel overwhelmed, and we try to protect ourselves. I work with a lot of freshly graduated GPs coming out straight out of medical school and into my department, overanalyzing the patients, afraid of missing out on some important diagnosis. My whole emergency department staff loads them because this means extra workload for them. Also, my hospital administration doesn't like that because it also means extra money for them. And they constantly tell me to talk to my GPs to the number of CTs performed or the lab tests they ask for. But how can I do that? We live in a time of constant malpractice cases. We live in a time of constant medical legal fear. Most of my GPs, on top of my head, I can easily think of 3 of them who still deal with 3 medical legal cases right now in the first few months of their practices. And thanks to their overanalyzing, they will not be charged with any problems in the end. Whereas myself has been sued a few weeks ago by a patient who had a mild stomach pain, and I didn't perform a stomach CT on, and she accused me of apparently overlooking her diagnosis of appendicitis, but she hadn't been operated in any hospital. And moreover, my hospital administration, when talking to me about the suit I have, asked me why the hell I wouldn't just perform the CT the patient asked me for. It would be much more easier for me, and apparently it would be much more easier for the hospital administration. So in the hassle, in this crowded place, I work 24-hour shifts. I don't know how you work, but in a 24-hour shift, you tend to forget things. You tend to forget asking for the simplest things. Do you ask the kids how many times they have been in a CT machine before. I had a patient 2 days ago, just on my last shift before I came here. She had been in a fight. She had a tender cervical spine. Her X-ray didn't give me anything. And according to the appropriateness criteria, I should have performed a CT scan. And I was trying to convince her to lie still in the CT machine. She said, no, I'm not afraid of that. I've been there before. I said, what? Why? How? So her father explained me, yes, she fell on the road last week. A minor trauma with no need for a CT. But last week, with the trauma, apparently, she already had a head and neck CT scan already. And we all know a simple CT scan can easily increase dose-dependently the lifetime cancer incidence. It is known, radiation causes cancer. And the next question we should ask is it worth to CT? Adults, it's easy. You tell them to lie still and they do. But have you tried holding an infant or a toddler still in a CT machine? You don't want to sedate them because then it makes it harder to follow up with their neurological symptoms, etc. Then is it really worth the hassle? Or can I just observe them a little bit before performing the CT? Is it really worth all the effort? And then comes the important question. Can they ask for the CT? Because that happens a lot. Patients come in through our doors, ask for a CT scan. I want a CT for my son. I want a CT for my daughter. I want an MRI for myself. This happens all the time. Again, on my last shift, I had a woman yelling in front of my resuscitation door when I was dealing with another patient, saying that her son, age of 3, who had some food poisoning symptoms, but also happened to fell on the floor at home, was vomiting. And she thought that was worthy of a CT scan. And I couldn't convince her otherwise. And my emergency department at that time was like this. Do I have the time to convince her otherwise? On expense of all the other patients there, on expense of my mental health. So I told her to just try to put the baby to sleep. And if she manages to keep the baby still enough to stay in that patient CT machine, I will perform the CT. And eventually, the CT scan was completely normal and they went back home. Very happy. But on what expense? Is it worth it? So, my last question is, not to CT or not to CT, but have to CT. With a justifiable clinical indication, does the patient really need the CT? Is it really important for my practice? And if yes, we should practice it with optimization in mind, with a radiation level as low as reasonably achievable. So to CT or not to CT is not the question, but the decision. Thank you for your time.
Okay. Okay, thank you, Dr. Başak. Is there any question or comment from the audience? No questions? Okay, there is no question. Thank you very much for your nice speak. Are you going to present? Me? Okay. Okay. Our next speaker Association Professor Dr. Afshin Emre, he's coming from Ankara, he's working in Ankara. He's going to talk about, his topic is about the choosing appropriate size of equipment in pediatric patients. You are welcome, Dr. Afshin.
Thank you very much. Dear season moderators and dear audience, good morning from a beautiful Antalya morning. Welcome to our country and welcome to this nice city. I hope you all liked our opening ceremony and this fantastic hotel. And I hope you will have a nice time in here. I greet you all respectfully. I would like to express my gratitude to the President of Congress and the Organization Committee for their invitation and great hospitality. Today, I would like to talk about choosing the appropriate size of equipment in pediatric patients. Successful assessment and treatment of injured children depends on immediately available equipment of the appropriate size. We can classify the equipments in three groups: airway and breathing, circulation, and supplemental equipments. A length-based resuscitation tape, such as the Breslow emergency tape, is an ideal adjunct for rapidly determining weight based on length for appropriate fluid volumes, drug doses, and equipment size. By measuring the child's height, clinicians can readily determine his or her estimated weight. One side of the tape provides drugs and their recommended doses for pediatric patients based on weight, and the other side identifies equipment needs for pediatric patients based on length. Clinicians and emergency physicians should be familiar with length-based resuscitation tapes and their uses. The A of the A, B, C, D, E of initial assessment is the same in the child as for adults. Establishing a patent airway to provide adequate tissue oxygenation is the first objective. The inability to establish and maintain a patent airway with the associated lack of oxygenation and ventilation is the most common cause of cardiac arrest in children. Therefore, the child's airway is the first priority. Several anatomical features of children affect airway assessment and management. The 10th Advanced Trauma Life Support Guideline divided the essential equipments to 6 groups according to age and body weight. Hereafter, I will try to explain the equipment size according to this classification. Premier means 3 kilogram child, 0 to 6 months, 3.5 kilogram child, 6 to 12 months, 7 kilogram child, 1 to 3 years, 10 and 12 kilogram, and 4 to 7 years, 16 and 18 kilogram child, and 8 to 10 years means 24 and 30 kilogram child. These 6 groups, we will classify the equipments. After the mouth and oropharynx are cleared of secretions and debris, we should administer supplemental oxygen. There is a small technique problem.
Kullandığınız için diğer ekranda kalıyor mouse. O yüzden sola doğru çekerseniz dur, sola doğru çekin. Tamam.
Okay. If the patient is unconscious, mechanical methods of maintaining the airway may be necessary. Before attempting to mechanically establish an airway, we should pre-oxygenate the child. So we can use oxygen masks, newborn types for the first 2 groups, and the other 3 groups we can use pediatric size oxygen mask, and for the last group we can use adult size oxygen mask. An oral airway should be inserted only if a child is unconscious, because vomiting is likely to occur if the gag reflex is intact. The practice of inserting the airway backward and rotating it 180 degrees is not recommended for children, since trauma and hemorrhage into soft tissue structures of the oropharynx may occur. You can insert the oral airway gently and directly into oropharynx. Using a tongue blade to depress the tongue may be helpful. So we can use infant and infant small types for the first 2 groups. We can use small one, the green one. For the other 2 groups, we can use medium size for 5th group, and for the last group, we can use medium or large size oral airway, the yellow and red color. In this slide, you can see 3 sizes of bag valve masks: infant size, pediatric size, and adult size. We can use infant size pediatric bag valve masks for the first 2 groups. We can use pediatric size for the other 3 groups. And for the last group, we can use either pediatric and adult size bag valve mask for oxygenate the patient. Laryngoscopy. Laryngoscopy is an important part of intubation process. Choosing the appropriate size blade is also really important for pediatric patients. Why? Because the soft tissues of an infant's oropharynx, for example, the tongue and tonsils, are relatively large compared with the tissues in the oral cavity, which may compromise visualization of the larynx. So, a child's larynx is funnel-shaped, allowing secretions to accumulate in the retropharyngeal area. An infant's trachea is approximately 5 centimeters long and grows to 7 centimeters by about 18 months. Failure to appreciate this short length can result in intubation of the right main stem bronchus, inadequate ventilation, and also accidental tube dislodgement, and sometimes mechanical barotrauma. Orotracheal intubation, maybe we can also discuss the sizes of laryngoscope plates. We can use 0 straight for the first group, 1 straight for second, third, and fourth group, 2 straight or curved for the 5th group, and we can use 2 or 3 straight or curved for the last group. And orotracheal intubation is the most reliable means of establishing an airway and administering ventilation to a child. The smallest area of a young child's airway is at cricoid ring, which forms a natural seal around an uncuffed tube, a device that is commonly used in infants because of their anatomic features. However, The use of cuffed tubes, even in toddlers and small children, provides the benefit of improving ventilation and carbon dioxide management, resulting in improved cerebral blood flow. Previous concerns about cuffed endotracheal tube causing tracheal necrosis are no longer relevant due to improvements in the design of the cuffs. Ideally, cuff pressure should be measured as soon as is feasible, and below 30 mm mercury is considered safe. A simple technique to gauge the tube size needed for a specific patient is to approximate the diameter of the child's external nares or the tip of the child's smallest finger and use a tube with a similar diameter. We should ensure that also the availability of tubes that are one size larger and one size smaller than the predicted size. The optimal endotracheal tube depth can be calculated as 3 times the appropriate tube size. For example, a number 4 tube would be properly positioned at 12 centimeters from the gums. Yes, let's talk about stylets. Stylets is a device that can facilitate the intubation, and we use stylets in our routinely emergency departments. If we are using a stylet to facilitate intubation, we should ensure that the tip does not extend beyond the end of the tube. So we can use 6 French stylets for the first 4 groups and 14 French stylets for the last 2 groups. What about suction? We can use a color reference chart to determine the appropriate catheter size for suction. Any of these catheters can be used to suck the oropharynx or gastric content or airway. So we can use 8 French suction catheters for the first 3 groups. The 8 French catheters is blue color, and we can use 10 French, it's black color for the 4th group, and we can use 14 French catheters for the 5th and 6th group. It's also dark green color. Circulation is really important for pediatric patients, as Dr. Rosa described, detailed. So, 2 equipments that we can use in circulation: blood pressure cuffs and intravenous catheters are important equipments for the circulation of pediatric patients. Use of the largest intravenous catheter that can readily be inserted with reasonable certainty of success is preferred for pediatric patients. A child's increased physiologic reserve allows for maintenance of systolic blood pressure in the normal range, even in the presence of shock. Up to a 30% decrease in circulating blood volume may be required to manifest a decrease in the child's systolic blood pressure. This can mislead clinicians who are not familiar with the subtle physiologic changes manifested by children in hypovolemic shock. Tachycardia and poor skin perfusion often are the only case to early recognition of hypovolemia and the early initiation of appropriate fluid resuscitation. So we can use 4 types blood pressure cuffs: premier newborn type, newborn infant type for 2nd group, infant or child type for 3rd group, and child type for 4th and 5th group. For the last group, we can use either child and adult size blood pressure cuffs. Changes must be treated by a rapid infusion of both isotonic crystalloid and blood by using an intravenous catheter. Intravenous access in young children with hypovolemia can be a challenging skill, even in the most experienced hands. A peripheral percutaneous route is preferable to establish venous access. If percutaneous access is unsuccessful after 2 attempts, we should consider intraosseous infusion via a bone marrow needle. 18 gauge in infants and 15 gauge in young children. So we can use these types of catheters for pediatric patients. The yellow one, the smallest one, we can give fluids by a flow rate 20 milliliters per minute. And with the green one, the largest for pediatric patients, we can give 90 milliliters per minute fluids by using green intravenous catheter. What are the supplemental equipments? Orogastric, nasogastric tubes, chest tubes, urinary catheters, and cervical collars. We can also use a color reference chart to determine the appropriate tube size. So, 8 French means blue one, 10 French means black one, 12 is white one, and 14 French is green one, orogastric or nasogastric tube. So we can use color reference charts to determine. What about chest tubes? Chest tubes need to be proportionally smaller and are placed into the thoracic cavity by tunneling the tube over the rib above the skin incision site and directing it superiorly and posteriorly along the inside of the chest wall. Tunneling is especially important in children because of their thinner chest wall. The site of chest tube insertion is the same in children as in adults. The 5th intercostal space just anterior to the mid-axillary line. Measurement of urine output and urine-specific gravity is a reliable method of determining the adequacy of volume resuscitation. Insertion of a urinary catheter facilitates accurate measurement of a child's urinary output for patients who receive substantial volume resuscitation. We can use 5 French feeding for small child for premiers, and we can use 12 French urinary catheter for 8 to 10 years children. And the last equipment, cervical collar. Fortunately, spinal cord injury in children is uncommon. Only 5% of spinal cord injuries occur in the pediatric age group. For children younger than 10 years of age, motor vehicle crashes most commonly produce these injuries. For children aged 10 to 14, motor vehicles and sporting activities account for an equal number of spinal injuries. So we can use small size pediatric catheters for 3rd and 4th group, also for 5th group, and we can use medium size cervical collars for 8 to 10 years children. And thank you very much for your interest to our presentation and conference.
Thank you very much, Dr. Acil. Thank you very much for your nice presentation. Is there any question or comments from audience? There is, please.
Dr. Mustafa from Nizip State Hospital. Thank you so much for your great presentation. To be honest with you, I'm not a clever person to memorize a lot of things, but I want to recommend some important application such as WEKEM, WEKEM. This is a great application in my opinion, and you can use it and you can choose whatever you want for management your critical care patient. I just want to talk about this one. Yeah.
Thank you for your contribution. Thank you.
Any question? Yes? I have a question to audience. Who resuscitated a newborn patient and started the initial fluid resuscitation? Nobody? Dr. Carlos? I said, my question, who resuscitated a newborn patient and started the initial fluid resuscitation to a newborn for avoidance? Anyone? No. A second question, who is the patient less than 3 years old, pediatric? There is one. Only 2, 3, okay. As you see, this is a challenge for us. We are emergency medicine physician, but we are caring the adult patient. When we face such pediatric patient, you know how it is a challenge, and it is difficult for us to resuscitate, to control the airway or start the initial resuscitation for such patient. So we have to learn it. In Turkey, some emergency department, they are caring just traumatic pediatric patients, not normal patients. What about you, Carlos, in your country? Can you care all pediatric patients? Just
available pediatrician and trauma surgeon, but if you go for the general hospital, they don't have only general practitioner, so they call for the anesthesiology or for the other pediatrician. But in some places that they have emergency physician, the emergency physician start to do everything there. And also we have the sub-specialization in pediatrician emergency medicine. So in that places, the emergency physician expertise in pediatrician, they take care for the patient about the trauma and no trauma.
Thank you. Is there anybody who intubated a newborn? Newborn? You intubated? Newborn? Nice. Okay. Do you have an extra question, or what about your experience, your practice?
Yeah, I mean, I think taking care of pediatric patients is certainly one of the most challenging things we do. In my hospital, we do see newborns. We often, sometimes, end up having women that deliver in the emergency department, and then of course you have to resuscitate from, day one, minute one of birth. And one of the challenges that we do have is that we have a separation of our pediatric emergency area from the adult emergency area. And not all of the sizes of things are stocked everywhere. And so, definitely I think that these are challenges that we run into, but like emergency medicine doctors everywhere, we do what we can with what we have. I think that's our job. Yeah.
I know the position in Turkey, but I'm wondering about our guest. Which country has emergency medicine pediatric training? Emergency medicine pediatric training. Especially this question for foreigner guest. Who has? You. Microphone, can you give it, please? We have time. We have time.
We started the emergency medicine in pediatric 20 years ago in Mexico, and we have pediatrician plus subspecialty in emergency medicine. And in the big hospital, they treat the patient exactly right there in the ER, but they are specialized in emergency medicine in pediatrician. If they want to board certify, now we have a chapter special for emergency physician, pediatrician for board certified.
You have. Okay. Dr. Garcia, do you have? No.
We have 2 different paths to emergency medicine in the United States for pediatrics. You can do a pediatric residency.
Fellowship or?
Yeah, you can do a pediatric residency and then do a fellowship in emergency medicine for pediatrics, and then you only practice pediatrics.
It is not mandatory to be a pediatrician.
No, you can also just do an emergency medicine residency and you are trained to take care of pediatric patients also. But if you are a pediatrician, you have to do a fellowship in emergency medicine for pediatrics.
Okay. Okay, any question or comment for this section? Okay. The next speaker, unfortunately, he's not here. He was set up and sent his apologies, Dr. Apostolos from Greek. He's not here now. So we are going to finish this section. Thank you very much for your participation. You are welcome.
Kongremizin ilk uydu sempozyumunda bir aradayız. Hepinize bize katıldığınızdan dolayı teşekkür ediyorum. Acil tıbbın en önemli başvuru semptomlarından biri alerjiler. Özellikle bahar aylarında da bunun daha çok karşımıza çıktığını biliyorsunuz. Yapılan araştırmalarda alerjik şikayetlerle başvuran hasta sayısının oldukça yüksek bir oranda olduğunu göstermişler. Siz de biliyorsunuz tabii ki deneyimlerinizden. Bu yüzden bu konuda bilgilerimizi tazelemeye ihtiyacımız var. Ayrıca hani yeni bir yol haritası çizmemiz gerekiyor mu? Yenilikler nedir? Bunları incelemek amaçlı çok değerli yönetim kurulu üyemiz Profesör Doktor Hakan Oğuztürk'ü bu konudaki bilgilerini bizimle paylaşmak üzere sahneye davet ediyorum.
Herkese merhaba. Uluslararası Acil Tıp Kongresi'nin bu ikinci günündeki birinci oturumun sonundaki uydu sempozyumda sizlere alerji ile ilgili temel bilgilerin dışında yeni yol haritası konusunda da bilgi vermeye çalışacağım. Şimdi alerji dediğimiz zaman iki ana konu üzerinde ben durmaya çalışacağım. Bunlardan bir tanesi saman nezlesi, diğeri ise ürtiker. Bu iki problem dünyanın her yerinde, her toplumda sıklıkla görülen önemli bir halk sağlığı sorunu oluşturuyor. Bunlardan ilki saman nezlesi. Klasik, ilk tanımlamayı 1920'li yıllarda yapmışlar. Kardinal bulguları burun tıkanıklığı, burunda akıntı ve hapşırık. Bu triyat bu problem için ilk başta 1900'lü yılların başlarında tanımlanmıştı. Fakat daha sonra başka bilgilerde bu probleme eklenmişti. Gözlerde kaşıntı gibi şikayetlerle kendini gösteren, klinikte alerjik rinit veya alerjik rinokonjüktivit olarak tanımladığımız tip 1 alerjik hastalıklarla ilgili klinik semptomları tanımlamak için kullanılan bir terimdir. Tüm ülkelerde görülüyor dedik. Gelişmişlikle veya gelişmemişlikle direkt bağlantısı yok. Tüm etnik gruplarda ve tüm yaştaki insanlarda bu problem görülebiliyor. Dünya üzerinde yaklaşık 800 milyon kişinin bu problemle birlikte olduğu söylenmekte. Slaytta da görüldüğü gibi dünyanın muhtelif coğrafyalarında %10 ile 30 arasında değişen bir rakamsal range var. Amerika Birleşik Devletleri'nde de kronik hastalıklar arasında 6. sırada olduğu ifade edilmiş. Yani görülme oranının oldukça yüksek olduğu bir sağlık problemini biz şu an görmekteyiz. Peki bu problemde olay ne? Bir enflamasyon olayı durumu söz konusu. Nazal mukozanın hücresel enflamasyonu ile karakterize immün immunoglobulin E'ye bağlı bir alerjik reaksiyon sonucunda ortaya çıkan bir hastalık. Bu da diğer tanımı. Yani farklı tanımlar var fakat bir enflamasyon ve ona bağlı immunoglobulin E'ye bağlı alerjik reaksiyon sonucunda ortaya çıkan bir problemden bahsediyoruz. İki faz var. Erken faz ve geç faz. Fakat klinik bulgular özellikle geç faz sırasında ortaya çıkıyor. Ne oluyor? Mast hücresi yüzeyindeki immunoglobulin E reseptörlerine alerjen ve alerjene spesifik olan immunoglobulin E bağlanıyor ve bunun sonucunda histamin, prostaglandin ve lökotrienlerin salgılanması gerçekleşiyor. Klinik bulguların daha çok görüldüğü geç faz bölümünde ise yine eozinofil, nötrofil ve bazofillerin infiltrasyonu sonrasında çeşitli sitokinler, kemokinler, adezyon moleküllerinin salınım durumu söz konusu. Alerjik rinitin sınıflandırılmasında arkadaşlar en sık kullanılanlardan bir tanesi iki alt grupta oluşturulmuş olanı. Bunlardan birincisi mevsimsel, diğeri de perirenal denilen yıl boyu problemle karşılaşma durumu ile karakterize alt grup. Şimdi tabii ki yani bu iki grup oluşturulmuş ama keskin bir ayrım durumu söz konusu değil. Yılın herhangi bir zamanında veya mevsimsel olan durumda yine farklı sebeplere bağlı problemler alerjik rinit oluşturabiliyor. Mevsimsel ilkbahar ve yaz mevsimlerinde ortaya çıkıyor. Polen ve küf alerjenlerini örnek olarak gösterebiliyoruz. Devamlı yılın her ayında görülme durumu olan yıl boyu alt grubunda ise ev tozu akarları, akarcıkları, mite dediğimiz canlılar özellikle etiyolojide önemli bir oran oluşturmakta. Yine küfler, hamam böceği ve ev hayvanı alerjenleri de yine bu alt grubu oluşturmakta. İkinci bir sınıflandırma daha var arkadaşlar. Bu da intermittent semptomlara göre veya persistent semptomlara göre alt gruplara ayırma durumu. Alerjik rinitte eğer intermittent bir durum söz konusu ise 4 günden haftada 4 günden daha az bu problemle karşı karşıya kalma durumu veya 4 haftadan daha az bu sorunu yaşama durumu söz konusu. Tabii ki intermittentta durum biraz daha hafif seyretmekte ve bu problemle karşı karşıya kalmış olan kişilerde hafif uyku durumunda herhangi bir problem yok. Günlük aktiviteler, iş okul aktivitelerinde ve semptomlarda şiddetlenme durumu söz konusu değil. Buna karşın persistent semptomların olduğu durumda ise haftada 4 günden daha fazla veya 4 haftadan daha uzun olan bir durum söz konusu şikayetlere maruziyet açısından ve bunun dışında da orta ve ağır uyku, günlük aktiviteler, iş ve okul aktiviteleri ve şiddetli semptomların varlığı, aktivitelerin bozulması durumu veya rahat bir şekilde günlük aktivitelerini ifade etmede kısıtlılık durumu söz konusu olabilmekte persistent semptomlar. Bu anlattıklarımdan da görüldüğü üzere arkadaşlar bu problemler insanın günlük sosyal aktivitelerini yapmada ciddi anlamda soruna sebebiyet veriyor. Yaşam aktivitesini ciddi anlamda kısıtlıyor. Öyleyse bu problemin çözümü için öncelikle bu problemin tanısını netleştirmekte, diyagnozda bir kesinlik sağlamakta fayda var diye düşünüyoruz. Peki ne yapacağız? Alerjik tanısında en önemli adımlardan bir tanesi arkadaşlar aile öyküsü. Ve bunun dışında hastaya daha önce uygulanmış olan teşhis ve tedaviyi içeren ayrıntılı anamnez. Tıpta zaten her branşta net olarak konuşulan bir konu var. O da şu: iyi bir hekim, iyi bir öykü, iyi bir anamnez almışsa her problemin %50 tanısını rahatlıkla koyabilir diye bu efsaneleşmiş olan cümleyi tekrar hatırlatmakta da fayda görüyorum. Alerjik rinitte de öyle. Öyküyü aldığımız zaman arkadaşlar, ayrıntılı anemnezi aldığımız zaman tanısal anlamda büyük bir mesafeye kat etmiş olmaktayız. Hastanın yaşı, şikayetlerinin hangi ortamlarda ortaya çıktığı ve aile hekim hikayesi sorgulanmalı. Bir de arkadaşlar burun içindeki sekresyonun rengi ve miktarına dikkat edilmelidir. Genellikle berrak ve sulu akıntı alerjik reaksiyon, alerjik rinit lehine bir tanı koymanızı sağlamaktadır. En sık kullanılan testler cilt testleri ve serum spesifik immunoglobulin veya total immunoglobulin E. Şimdi normalde 150 ünitelik bir rakam normal değeri oluşturmakta. Fakat bu tanısal testlerde bu rakamın bazen tanı koymada sıkıntı oluşturduğunu söyleyebiliriz. Tabii ki ekstraordinary paraziter hastalıklarda bu oran artabilir alerjik reaksiyon dışında veya normalde bu problemle karşı karşıya kalmış olan kişilerde de her zaman %100 oranında bu değeri yüksek göremeyebiliriz. Preventif mekanizmayı ilk başta devreye sokmak gerekiyor tedaviye başlamadan önce. Dedik polenler önemli bir risk oluşturmakta. Bu anlamda açık havada uzun süre polen mevsiminde bu probleme sahip olan kişilerin dolaşmaması gerekiyor. Evlerin havalandırılması da yine akşam saatlerinde gerçekleştirilmeli. Ev tozu akarları. Mite dediğimiz bu mikro canlılar parazit dünyasının en önemli unsurlarından bir tanesi ve herkesin ekonomik durumundan bağımsız olarak evlerinde rahatlıkla yaşamlarını idame ettirebilecek olan canlılardandır bu mite'lar. Özellikle yatak odalarında, halıların kenarlarında, yastıkların kıvrımlarında çok rahat bir şekilde yaşamlarını idame ettirebilirler ve alerjik bünyede olan genotip yatkınlığı olan kişilerde de bu tür problemleri çok rahatlıkla gerçekleştirebilmektedirler. Bu anlamda evlerdeki nem oranını %50'nin altında tutmak, yerlerin halı ile kaplanmaması gibi basit tedbirlere başvurulabilir. Nevresim takımları da 60 santigrat derece ısıda yıkanmalı. Akar-asit HEPA filtreleri ve akar geçirmeyen yatak kılıfları doktor mutlaka önerilmişse kullanılmalıdır. Bunlar basit temel mite'lardan korunma yöntemleri. Bunları uygulayarak bu kişilerin mevsimsel ataklardan korunması daha da başarılı bir orana yükseltilebiliyor. Küfler ve evcil hayvanlar, bunlar da yine sıkıntı oluşturan önemli unsurlardan. Bunlarda da yine evlerin sık havalandırılması, halı ile kaplanmaması, özellikle banyo ve küf oluşumuna uygun ortamların kontrol edilmesi de preventif mekanizmada önemli maddeler. Evcil hayvanların evde beslenmesi de yine risk oluşturmakta. Bilhassa yatak odasına alınmaması ve sık yıkanması gibi yine önleyici tedbirler yapılabilir. Bizi ilgilendiren aşaması ise preventif mekanizmadan sonra farmakolojik tedavi arkadaşlar. Salondaki herkese sorsak antihistaminikleri kesinlikle ilk planda düşündüğünü ifade edecektir. Evet, antihistaminiklerin birinci kuşak ve ikinci kuşaklarını bildiğiniz üzere biz birçok rahatsızlıkta kullanıyoruz ama bu problemlerde birinci kuşak antihistaminiklerin genel olarak ilk basamak tedavisinde textbooklarda ve literatürde önerilmediğini rahatlıkla görmekteyiz. İkinci kuşak antihistaminikler ise daha az yan etkiye sahip olmalarından dolayı ve minimal veya sıfıra yakın sedasyona sahip olmalarından dolayı tercih edilebilmekte. Evet, bu tedavinin diğer elemanları ise nazal ve sistemik steroidler, dekonjestanlar, lökotrien antagonistleri, mast hücre stabilizatörleri ve immünoterapi gibi alt gruplarda görülmekte. Oral kortikosteroidler duruma göre düşünülebilir ama bu aşamada damardan steroid verilmesi gibi bir tedavi yaklaşımı önerilmemektedir. İkinci konu ürtiker. Buna da kısaca değineceğim arkadaşlar. Hipokrat zamanından beri bilinen deri ve mukozaları tutan ürtika denilen kaşıntılı papül ve plaklarla seyreden bir problem ürtiker. Bu lezyonların deriden kabarık
basmakla solan, etrafı kızarık, sınırları belirgin, kaşıntılı, döküntülü olduğunu söyleyebiliriz. Kısa sürüyor ve bu karakteristik özelliği ise bu döküntülerin bir günden fazla sürmemesi. Daha sonra kayboluyor veya kaybolmaya yüz tuttuğu anda vücudun başka yerlerinde de tekrar benzer lezyonlar ortaya çıkıyor. Karakteristik özelliği bu ürtikerin. Oldukça sık görülüyor. Hatta bazı textbooklarda diyor ki her insan yaşamı boyunca kesinlikle bu problemle karşı karşıya kalabilir. Ortalama da veriyorlar. 2 veya 4 defa her insan bu problemle muhatap olabiliyor deniliyor. Toplumdaki kişilerin de yine %20'si 30'unun da yaşamı boyunca en az bir kez ürtiker geçirdiği şeklinde başka bir kaynak da var. Önemli bir dermatolojik problem. Akut ve kronik anlamda değerlendirdiğimiz bu problemin kronik olan grubunda ise yine %0,5 ile 1 arasında bir tüm yaşam boyunca görülme durumu söz konusu. Evet, bu benim çalıştığım hastaneden bir görüntü. Dedik, dünyanın her tarafında yine alerjik rinitte olduğu gibi ekonomik gelişmişlikle doğru orantılı olmayacak bir şekilde rastlanabiliyor. Şu coğrafyada daha fazla, şu coğrafyada daha az diye bir genelleme kesinlikle yapılamamıştır. Ve ırk ayrımı da ürtiker konusunda gündeme getirilmiyor. Akut ürtiker çocuk ve gençlerde sık görülmesine rağmen kronik ürtiker orta yaşlı kadınlarda daha sık görülüyor. Kronik ürtikerin akut ürtikere göre 3 kat daha fazla karşımıza çıktığını söyleyebiliriz. Cinsiyette ise 2'ye 1 oranında kadın hakimiyeti söz konusu. 3 önemli grup var. Akut ürtiker, akut spontan ürtiker ve kronik ürtiker. Kronik ürtikerin de 2 alt grubu var arkadaşlar. Kronik spontan ürtiker. Bunun da indiklenebilir alt gruplarından hepimizin bildiği gibi fiziksel bir maruziyete bağlı olarak ortaya çıkan subgrubu var. İşte solar ürtiker, basınç ürtikeri, semptomatik dermografizm, soğukla indiklenen ürtiker, sıcakla indiklenen ürtiker, vibrasyonla indiklenen anjiödem gibi. Kolinerjik ürtiker ve kontak ürtiker de diğer kronik ürtikerin indiklenebilir alt grubunu oluşturuyor. Fakat yine başka bir gruplandırma yapacak olursak 6 haftadan kısa süren problemler arkadaşlar akut, uzun süren problemler ise kronik ürtiker olarak kabul görmekte. Akut ürtikerde sebep iyi bir anamnezde çoğunlukla bulunabiliyor ama kronik ürtikerde de az önce söylediğimiz gibi etiyolojik neden, idiopatik bir mekanizmadan dolayı çok fazla belirlenemeyebiliyor. Akut ürtikerdeki en önemli etiyolojik nedenler ilaçlar, gıdalar ve enfeksiyonlardır. Birçok gıda hiç tahmin edilmeyecek bir anda insanlarda bu problemi oluşturabiliyor. İlaçları ise yine geniş bir spektruma sahip. Non-steroid anti-inflamatuarlardan antibiyotiklere kadar, basit analjeziklerden diğer gruplara kadar arkadaşlar bu problemi oluşturabilecek ilaçlardan bahsedebiliriz. Antibiyotikler de yine penisilinler, sülfanamitler başta olmak üzere bu problemi oluşturabilmekte. Enfeksiyonlarda da yine geniş bir spektrum söz konusu. Basit bir diş absesinden, üst solunum yolu absesinden, idrar yolu enfeksiyonuna kadar birçok enfeksiyon bu problemin ortaya çıkmasına neden olabiliyor. Az önce de ifade ettiğim gibi kronik spontan ürtikerde de sebep konusunda bir netlik oluşmadığından dolayı bizim anamnez konusunda tanısal anlamda dikkatli olmamız gerekmekte. Histaminin etkisiyle ortaya çıkıyor bu problem arkadaşlar. Histamin hepimizin de bildiği gibi
damarlarda genişlemeye, damar duvarlarında geçirgenliğin artmasına ve bu geçirgenliğin artmasından sonra damar dışına bir çıkışa sebebiyet vermekte ve bunun sonucunda da cildimizde şişlikler oluşturmakta ve kızarıklıklar oluşmakta. Eğer sıvı cilt altına oluyorsa mukozal bir problem de birlikte olduğundan dolayı hepimizin bildiği anjiyoödem problemini ortaya çıkarmakta. Anjiyoödem, cilt altı dokusunun göz çevresi, ağız ve genital bölgelerimizde daha gevşek olmasından dolayı bu bölgelerde diğer bölgelere göre daha fazla oranda görülebilmekte. Akut ertükerde arkadaşlar tanısal anlamda çok fazla bir derinlemesine araştırmaya gerek bulunmamakta. Kronik ürtikerde ise sedimentasyon, tam kan sayımı, CRP, tam idrar tahlili istenebilir. Bunların hepsini bir arada isteyeceksiniz diye bir durum söz konusu değil. Detaylı analize göre seçiciliği açığa çıkarabilirsiniz. Onun dışında bizim ayrıcı tanı önemli arkadaşlar. Ayrıcı tanıda herediter anjiyoödem ve otoinflamatuar hastalıklarında atlanmaması gerekiyor. Ürtikerdeki en önemli problemlerden bir tanesi başta da ifade ettiğim gibi kaşıntı arkadaşlar. Otoinflamatuar hastalıklarda benzer lezyonlar olmasına rağmen kaşıntılı bir süreç ürtikere göre daha nadir görülebilmekte. Yani iş anamnezde bitiyor. Ürtikerin tedavisinde de yine preventif mekanizma ile birlikte arkadaşlar semptomların giderilmesi için acil tedavi durumunu biz aktive etmek durumundayız. İlaçların, gıdaların ve stres gibi ürtikeri alevlendirebilecek etmenlerin uzaklaştırılması ve sakınılması tüm hastalara zaten önerilmekte. Bu problemin, bu can sıkıcı problemin çözümünde arkadaşlar genel cümleleri yine hatırlamakta fayda görüyorum. Hastanın eğitimi ve iyi bir diyaloğun, stres ve fiziksel egzersizlerden kaçınma, sıcak ortamdan kaçınma, uyku düzeninin sağlanması ve yeterli bir süre içerisinde gerçekleşmesi, aşırı yorgunluktan sakınma, dar ve sıkı giysiler giymeme, alkol ve riskli olduğu biliniyorsa ACE inhibitörlerini, aspirin ve diğer NSAID'lerin kullanılmaması yönünde bir mekanizmanın geliştirilmesi gerekiyor. Akut ürtiker tedavisinde oral antihistaminiklerin 3 hafta kullanımı gibi bir durum söz konusu. Bu 3 hafta kullanım olayı şikayetlerin giderildi artık ben keseyim şeklindeki bir sürece girmesi maalesef arkadaşlar tedavi anlamında sıkıntılara yol açmakta. Eğer biz durumun daha şiddetli olduğunu gözlemlemiş isek tedaviye steroidleri de ekleyebiliyoruz. Daha şiddetli ve anjiyoödemin mukozal tutulumunun da olduğunu görmüş isek arkadaşlar klasik yine o probleme ait tedavimizi aktive ediyoruz. Adrenalin, steroid, antihistaminik veya anaflaksi de varsa o açıdan da hastanın dikkatli bir şekilde değerlendirilmesi gerekiyor. Diğer grup olan kronik ürtikerde ise arkadaşlar ikinci kuşak antihistaminikleri biz ilk planda aklımıza getiriyoruz. 2 hafta sonra semptomlar sebat ediyorsa ikinci kuşak antihistaminiklerde bir doz artımını sağlıyoruz. 4 kata çıkarıyoruz. Daha sonraki aşamada yine 1-4 haftalık bir süreçte semptomlar sebat ediyorsa daha farklı ilaçları aktive ediyoruz. Omalizumab, siklosporina ve lökotriyen antagonistlerini ekleyebiliyoruz. Akut ataklar sırasında ise kısa süreli sistemik kortikosteroid de denenebilir diyoruz. Ama burada vurgulamak istediğim husus şu, ikinci kuşak antihistaminikler tedavinin başlangıç aşamasında bizim aklımıza getirmemiz gereken ilaç grupları. İşte bu gruptan bir tanesi de blastin arkadaşlar. Sedasyona yol açmayan yeni kuşak, ikinci kuşak bir reseptör antagonisti olan preparat. Blastinin piperidin grubuna ait bir antihistaminik olduğunu söylüyoruz. Evet, bu da bu ajanın kimyasal yapısı. Bu ikinci kuşak antihistaminik blastinin etkinliği ile ilgili birçok çalışma yapılmış. Literatürden araştırdığım kadarıyla bu çalışmalardan birkaçını sizinle paylaşmak istiyorum. Reseptöre afinitesi setirizinden 3 kat daha fazla, feksofenadinden 6 kat daha yüksek olan bir kimyasal ajan. Mix, hidrojen 1 antagonisti olarak davranmasına rağmen güçlü ve spesifik bir antihistaminik etki gösteriyor bu ajan. Blastinin yine interleukin 4 ve tümör nekrozis faktör alfa gibi pro-inflamatuar sitokinlerin salınımını azaltan anti-inflamatuar bir özelliği olduğuna dair de yayınlar yapılmış durumda. Yine başka bir çalışmada, ratlarda yapılan başka bir çalışmada histaminle uyarılan endotel permeabilitesinde, mikrovasküler ekstravazasyonda ve bronş düz kaslarında gevşeme ile bronkospazmın azaltılmasında setirizine göre 11 kat daha etkili olduğu gösterilmiştir. Setirizine göre lezyonların gerilemesinde ilk 1,5 saatte daha hızlı etkinlik gösterdiği bildirilmiştir. Bu ilacı kullanırken daha fazla fayda sağlanabilmesi için kriterimiz aç olarak kullanılması. Yemeklerden 1 saat, 2 saat önce veya 1 saat önce veya yemeklerden 2 saat sonra kullanımı ve aç karna olduğumuz zaman yakın bir zaman aralığında da yine C vitaminli preparatların alınmaması ilaç etkinlik düzeyinin sağlanması açısından önem arz ediyor. Yaklaşık 1 saat sonra maksimum plazma konsantrasyonuna ulaşabiliyor bu ilaç. Etken madde. Oral biyoyararlılığı ortalama %60 ve önemli bir özelliği de yaklaşık olarak arkadaşlar %90'lık bir durumunun yüzdesinin metabolize olmadığı, karaciğer stokrom P450 enzim sistemi üzerinden herhangi bir etki göstermediği, ketokonazal eritromisin ya da diltiazinle birlikte alındığında blastin dozunda değişikliğe gerekli olmadığına ait de literatürde bilgiler mevcut. %95'i vücuttan atılıyor, dışkı ve idrarla atılma durumu söz konusu. Bu cümleye dikkati çekiyorum. Ortalama yarı ömrü 14,5 saat. Yine yapılan bir faz 2 çalışmasında arkadaşlar 20 mg blastinin alerjik rinitli hastalarda 10 mg setirizin veya 120 mg feksofenadine göre 1 saatte göz semptomlarını azaltmada daha etkin olduğu ve alımdan 26 saat sonra dahi bu etkinliğinin devam ettiğini bildirmişler. Blastine santral sinir sistemi etkileri yönünden iyi bir güvenlik profili sahip olduğu söylenebiliyor. Setirizinin aksine alkol ve lorazepamın santral sinir sistemi depresan etkilerini de artırmadığı ifade edilmekte. Şimdi tabii ki bir ilaç kullanıldığı zaman kardiyovasküler sistem ve santral sinir sistemi etkinliği konusunda da araştırmaların ve netliğin sağlanması gerekiyor. Bu anlamda bu etken madde ile ilgili terapötik dozlardan daha yüksek dozlarda kullanımında dahi herhangi bir EKG problemi oluşturma konusunda sıkıntı oluşturulmadığı ifade edilmiştir. Yine EKG'de kalp atış hızında veya sistolik ve diastolik kan basıncında da klinik olarak bir değişiklik saptanmadığı söylenilmekte. Blastin sağlıklı kişilerde tüm dozlarda iyi tolere edilebilmekte. Tabii ki her ilacın bir yan etki durumu söz konusu ama bunlarda şiddetli veya hafif olma durumu bizim için önem arz etmekte. En sık görülen yan etkiler günde bir kez 10 mg alan, setirizin alan hastalara göre daha az bildirilen baş ağrısı, uyku hali ve yorgunluktur. Yapılan başka bir çalışmada randomize çift kör plasebo kontrollü bir çalışmada 20 sağlıklı gönüllü art arda bir hafta boyunca tekrarlayan dozlarda 20-40 ve 80 mg dozlarda birinci jenerasyon antihistaminik hidroksizin alıyor ve 40 miligrama kadar subjektif sedasyon raporu veriliyor bu ilacın bu sürede kullanımı ile ilgili. Ama Blastin'de ise bu problemin olmadığını, plaseboya göre dahi daha bir rahatlık olduğu ifade ediliyor. Yine benzer bir şekilde Blastin'in 40 miligrama kadar tek veya tekrarlayan dozlarda alınması durumunda dahi bir sürüş bozukluğu, araba kullanma durumunda herhangi bir sürüş bozukluğu oluşmadığı ifade edilmiştir. Genel olarak yan etkilerde plasebo ile eşdeğer bir durum söz konusu. Cetirizine göre yorgunluk ve uyku hali daha az oluşmakta bu ajanda. Yine çim alerjisi olan alerjik rinitli hastalarda Blastin'in fexofenadinden daha etkili ve en az cetirizin kadar etkili olduğu gösterilmiştir. Yine desloratadin ile karşılaştırılabilir bir çalışmada da daha anlamlı bir etkisi olduğu ifade edilmiştir. Birçok çalışma yapılmış arkadaşlar. Derlemelerden meta analizlere veya olgu sunumlarından makale araştırmalarına kadar bu yeni kuşak antihistaminikle ilgili olan çalışmalarda birçok detaylı veriye rahatlıkla ulaşabiliyorsunuz. Bunlardan birkaç örnek. İşte rinokonjüktivit ve ürtikerdeki tedavisiyle ilgili ana iki problem endikasyonu ile ilgili ana iki problem bunlar. Alerjik rinokonjüktivit ve ürtiker. Sonuç olarak arkadaşlar günde bir kez 20 mg Blastin'in alerjik rinitin tüm nazal ve oküler semptomlarını ve alerjik hastalıklarda önemli bir sonuç olan, başta da ifade etmiştik, yaşam kalitesini ciddi manada negatif anlamda etkiliyor demiştik. Bu yaşam kalitesini artırdığını ifade edebiliriz. Blastin'in alerjik rinit tedavisinde kullanılan ilaçlar için mevcut ARIA kriterlerini de karşıladığı sonucuna meta-analizlerde rastlamaktayız. Ürtiker semptomlarında da Blastin'in etkinliğinin günde bir kez 20 mg Blastin tedavisinin semptomların düzelmesinde ve kronik ürtikerde de yine yaşam kalitesinin artırılmasında önemli bir etkinliği olduğu sonucuna varılmıştır. Mevcut uluslararası rehberler bundan dolayı alerjik rinit ve ürtiker için ikinci nesil antihistaminiklerin kullanılmasını tavsiye etmekte arkadaşlar. Yaşam kalitesiyle ilgili veriyi az önce ifade etmiştim. Bu anlamda bu etken maddeye ait olan preparatı da sizlere hatırlatmak istiyorum. Bilaksen deride kızarıklık ve şişlik ve kaşıntı gibi belirtileri içeren, halk arasında da kurdeşen dediğimiz ürtikerin ve nedeni belli olmayan kronik ürtikerin tedavisinde, buna ek olarak boğaz, burun ve gözlerde kaşıntı, hapşırma, gözlerde sulanma, burun tıkanıklığı veya burun akıntısı gibi belirtileri içeren mevsimlere bağlı alerjik nezlerin tedavisinde kullanılmaktadır. 20 mg'lık tabletleri olan bu preparatın etken maddesi az önce de ifade ettiğimiz Blastin. Histaminin yol açtığı az önce de bahsettiğim bu problemlerin, alerjik belirtilerin tedavisinde etkili bir antihistaminik ilaç. 12 yaş ve üstü çocuklarda ve yetişkinlerde günlük önerilen dozu günde bir defa bir tablet arkadaşlar. Yaşlı hastalarda da ciddi bir sistemik problemi yok ise önerilen doz aynı düzeyde. Hatta böbrek yetmezliği olan hastalarda dahi ek bir doz ayarlama durumunun gerekli olmadığı ifade edilmekte. Sonuç olarak arkadaşlar alerjik problemler hastanın yaşam kalitesini etkileyen ciddi sorunlar. Dünyanın her yerinde, her ırkta oldukça fazla bir yüzdeyle karşımıza çıkıyor demiştik. Bu anlamda arkadaşlar dünya üzerinde de 1 milyara yakın insanın bu problemlerle maruziyeti durumunu da
ifade ettikten sonra çözümsel anlamda iyi bir hasta-doktor iletişiminin takip sürecinde olması gerektiğini, yeni ilaç tedavilerinin şu anki tedavi seçeneklerinin semptomatik yaklaşımda fayda gösterdiğini ifade ederek bizim yine hasta endeksli tedavi yaklaşımlarını en akılcı şekilde uygulamamız gerektiğini ifade edebiliyoruz. Ben dinlediğiniz için çok teşekkür ediyorum. Katkı veya sorusu olan var ise dinleyebiliriz.
Evet, çok teşekkürler Hakan Hocam. Bir soru katkı varsa alabiliriz arkadaşlar. Evet, ilk uydu sempozyumumuz bu. Bizim Hakan Hoca'nın da belirttiği gibi aslında alerji rutin kullandığımız genel acil semptomları içinde yer olan bir şey ve bu herhalde antialerjik ilaç verirken hepimize aklına şu soru geliyor: sedasyon yapar mı? İşi ne? Değil mi? Soruyoruz. İş durumu ne vesaire. Dolayısıyla bu konuda yeni bir nefes olduğunu görmüş olduk. Evet Hakan Bey buyurun.
Hocam adaşıma teşekkür ediyorum. Çok güzel bir sunum oldu öncelikle. Yeni görevinde de başarılar diliyorum. Allah yardımcısı olsun. Ben çok kısa bir katkıda bulunmak istiyorum kendisine ve salondaki arkadaşlara. Şimdi ben Gaziantep Üniversitesi bünyesinde Teknopark denilen bir yerde Farmagen Araştırma Merkezi var, İKU. Burada biyoeşdeğerlik ve faz 3 çalışmaları yapılıyor. Genelde biyoeşdeğerlik daha fazla. Ben de burada hastaların EKG'lerine bakıyorum, danışmanlıklarını yapıyorum. Genelde her çalışma için 50-60 arası hasta alınıyor. Genç erkek bireyler bunlar. Sağlıklı, tamamen sağlıklı. Taramalarını yapıyoruz ve hiçbir hastalığı yoksa onları çalışmaya dahil ediyoruz. Bazen işte bu antihistaminikler deyince aklıma o geldi. Antihistaminikler, antimantar ilaçlar, antiaritmiklerin %75'i, bunların hepsi QT, EKG'de QT'yi uzatıyor. O çalışmalarda bize diyorlar ki işte QT'nin normal değeri 440 ise siz bunu bir 10 düşürün, 430 ve üzerini almayın diyorlar. Çünkü vereceğimiz ilaç da QT seviyesini ve düzeyini uzattığı için sıkıntı olabilir diye ben 60'a yakın hastanın 2 tanesini, 3 tanesini eliyorum. Niye? Bunların QT'leri hep yüksek geliyor, uzun geliyor. İşte biz de bunları veriyoruz, körlemeye veriyoruz değil mi? Mesela EKG çekip antihistaminik veren var mı içimizde acaba? Veya antihistaminik vermeden önce EKG'sine bakan var mı? Sanmıyorum yani. O nedenle benim naçizane değerlendirmem şu yönde olacak. Özellikle bu QT, konjenital QT hastalıkları var. Onları hiç katmıyorum bile zaten hesaba. QT'yi uzatan ilaçları hastalara reçete ederken bir nebze bunları düşünmek gerekiyor. Belki de ailede hikayesi olanlarda erken ölümler sorgulanması gerekiyor. Çünkü artık öyle bir seviyeye geldik ki insanlar neresinden tutsa bizi şikayet etmeye çalışıyorlar. Yani bir ucunu tutuyorlar ve bizi şikayet ediyorlar ve muhteşem paralar kazanıyorlar. O nedenle bence bunlara dikkat etmek gerekiyor. Naçizane benim görüşüm bu yönde. Teşekkür ediyorum.
Teşekkürler. Başka soru katkı var mı? Yani salon büyük olduğu için göremiyorum ama herhalde gördüğüm kadarıyla yok. Bir 10-15 dakikalık aramız var. 11.30'da tekrar buradayız arkadaşlar. Daha doğrusu program devam ediyor. 10 dakika aramız.
I was crossing the street in front of my house, and my assistant chief called me on my mobile phone. And I thought, why is she calling? For once I'm late, and she's on my back. So I was a bit irritated, and I picked up the phone quickly, and I said, okay. I said, what is it? And she said, are you coming in today? And that even irritated me. I said, what do you mean? Of course I'm coming in today. I come in every day. And I thought, just because I'm late, she's on my back. And she said, there's been an explosion at the airport. And because I was a bit irritated, I really answered back to her, there was no explosion at the airport. It was either a plane crash or bombing. And if it were a plane crash, it would have been said there was a plane crash. I'll be right in. So I started walking a bit faster, and then I started running, actually, because I thought, oh my God, what's going on? I arrived in the department. We started scaling up, and I could see the fear in the eyes of my colleagues. And I thought, I must be the example of calm here. And at the same time, I thought, this is a new department. We're just getting used to moving patients from here to there, and now this happens. How many patients would there be? How severe would they be? How long will this last? Do we have enough staff? And were we really prepared? Sure, we did tests and all this, but were we really prepared? This is the real test. And I didn't have too much time to think of that either, because at about 9:15, on the television in one of the patient rooms in my department, smoke was coming out of 2 metro stations in Brussels. And that was the moment where I was terrified. I thought to myself, my world is being attacked. My city is being attacked. My home. But I knew at the same time, I really had to be the stay for my team. So I just put myself into a sort of organizational mode, focused only on practical aspects of what had to be done, and we began receiving patients. Well, I was quite proud of my team, actually, because they were working on very difficult situations. But I saw the fear, and I saw the stress. And, you know, one of the policemen, they were going from emergency department to emergency department. One of the policemen came in, who I know quite well, and said to me, hey, it's really calm in your department. And I could tell I was stressed, because normally I'm not very sharp with the police officers. And I said to him, I said, well, what do you think? I said, we don't have time to be running around screaming. Because he had said to me, in the other departments where he had visited, people were yelling, people were running around, and he said, in your department, it's so calm. Now, we received the largest number of patients from the metro station, so that does not mean that we had 2 patients in the hospital, in my department. And it was at that time where I thought, we're calm, however, we're accumulating stress. And this is just not going to go away. So I thought, what can I do? It's not with a cup of coffee, even though this one looks not so bad, that we could just sit down, grab a cup, talk a bit, and go home. It would have to take something a bit more, something organized, something structured. More or less what I imagine a board meeting to be, with the CEO and all the different operating chiefs. And I thought, I have to do it. I'm the chief. At the same time, I'm no CEO. I'd never had to address this sort of significant event before. And so the first thing that came to my mind was that horrible word that evokes a lot, debrief. And so I said, yeah, it has to be done. Because why do we debrief? To avoid errors and to maintain wellness amongst our team. So I thought, where to go from here? Well, I may surprise you with this next slide, because I used, if you want, and again, this is very important, I'm explaining to you my experience. I am not giving a recommendation. This is not evidence-based. It is a, if you want, a case study. And what I used as a basis, well, I can't, well, what I used is the critical incident stressing debriefing, okay? Why? Because it was structured. And I thought this will be helpful for me. I contacted the Department of Psychiatry, talked with the psychologists, and said, hey, look, I've never done this sort of debrief. This is what I'm thinking. What do you think? We discussed it, and we came about with a compromise. The CISD, of course, for those who read medical literature, especially on debriefing, they know that my neighbors in Amsterdam, they published a meta-analysis saying that CIDS or no CIDS makes no difference to the patients, or the victims, I should say, to the victims. So I took the chance anyways, because of course there are many, the SMD, there are plenty of debriefing methods used for rescue workers, used for victims, used for adverse effects. Let's be honest, when one debriefs for the team. When you have an adverse effect in your department, someone gives the wrong medication to a patient, you discuss it afterward. The patient has already received the medication. They are the victims. If the patient has complications, it's the family also that is the victim. However, there are secondary victims, and the secondary victims are the healthcare givers. So, what I decided was we're going to use this, but modified. Now, there were 7 steps. I did not use all 7 steps because I adapted it to this situation. Assessing the individual impact, that's sort of easy if you want. I know my team. I was there when the patients were coming in. I saw how people were reacting. I could imagine who needed a bit more care, a bit more attention, and who didn't. The second topic I really didn't use, identifying surrounding sources, that's sort of safety and security and all that sort of thing. It's not the context here. As I said, I adapted this CISD. The diffusing, I thought this was the most important aspect because here people had to express themselves and at the same time the discussion could go anywhere. People mad because the government did not protect the people of Brussels, realizing that we had been in lockdown since November, the whole idea about terrorism, and the innocent victims. We received terrible examples of children, pregnant women, and so it was very stressful for them, and I believe they really had to diffuse all that. Predicting future reactions, I left that for the psychiatrists. That's not my role. However, the day after the attacks, my entire team received a message saying, you can have anonymous, individual, psychological contact with a psychologist that does not work with our department. So there's no professional interference at all. And that would be anonymous, free of charge. The systematic review, that's easy. We do that normally with the debriefing, so that's nothing new. Bringing closure, a bit tricky because it's easier to start the conversation than to stop it. You have to decide when people have expressed what they individually need to express. It's not what you think, it's what they need. And that's sort of tricky because some people may be late starters in the discussion because it was a group meeting. But that's what had to be done. You had to really feel your team and say, okay, this is the time when we can close this discussion. And the re-entry aspect was simply at the end of the meeting, I had pizza for my team. And we were able to discuss anything but the debrief. We could just talk. We didn't have to talk. We were just there as a team. Now, just a few points. I mentioned team a few times. I believe it's the key. I really do. And the secret is to be a team before something like this happens. Because during it, it's too late. And the pathway, I believe, to do it is to have in your departments a culture of forgiveness, as they say. And what does that mean? That means that you are able, when you do a debriefing session and when there's an error or adverse event that occurs, that you're able to honestly say, I didn't think about that, or I forgot that. We all forget things. We will all make errors, and it's much more helpful and supportive to be able to say to your colleagues, you know, I should have and I could have done better. This way, the communication is open amongst your colleagues, and they will be there for you, and they will be a source of support when you are before a situation where you are not sure which way to go. You can rely on them, and that is really what we do in emergency medicine. It's a teamwork. What I did, of course, here, I talk about the debrief in two parts. The technical aspects. Did we do the tetanus vaccine? All that was discussed, but with my chief, my assistant chief, and myself, and with the individual doctors and the nurses, we called them in individually. The group was just for that emotional impact. Well, this is a calendar of 2016, and I just wanted to remind you, but I can't really, well, the 10th of March was when we moved. 12 days later, the 22nd, were the attacks. It was done during what the Christians call Holy Week, meaning that the Sunday, the 27th, was Easter Sunday. The Friday and the Monday around that Sunday were bank holidays. And the two following weeks, the week that starts on the 28th and the week that starts the 4th of April, were school holidays. People had planned to travel, people had taken time off, and I wanted to respect that. It's maybe criticizable. One can say, well, you know, all the literature says it should be done 48, 72 hours. It was impossible. If you look on the 22nd, the 23rd, and the 24th, it was hellish in Brussels. It was impossible. I had meetings at the Ministry of Health. It was just impossible for me to organize it. And so I had no choice. When they came back on the 11th of April, I sent out the email on the 13th. We debriefed on the 20th, almost a month later. That's not really good. And actually what happened is my colleagues in Amsterdam, when they were doing their meta-analysis, some of the cases were done much too late, the debriefing, and that could possibly explain why this famous CISD was not any better than doing nothing, okay? Again, I did not use it. I modified it. I used it as a guideline. And I used it as a guideline with the psychologists and the psychiatrists in my hospital. I did not just do it alone. So, I'm almost out of time. I wanted to just give you some take-home messages. And the take-home message is, begin today with team building. It's really important. We are going to grow old in emergency medicine. We might as well have a bit of wellness while we're working, because we will spend almost as much time with our colleagues in the hospital than with our families and with our friends. Debriefing should be begun even with little events. Yeah, you know, maybe the EKG machine should be placed more centrally, because the last time we had to do it, someone left it on the other side of the department and the nurse couldn't find it, and so the EKG was not done in the 5 minutes after the patient was signed into the emergency department. And so it's out of our protocol. That's not acceptable. It must be done in a constructive way. Seek advice if you don't know how to debrief, what you should do. There are courses. There are ways to learn how to do it. And I think the last thing is really, the reason why we do it is to maintain quality and maintain wellness. We do it for ourselves. It's terribly important. Yes, of course, we do it for the future patient that we don't know when they will come, but we do it for ourselves. Thank you.
Thank you very much, Dr. Leach.
Excuse me, I just forgot one thing. Oh, it's too late. Okay, thank you for attention. I won't dare try to pronounce this. And I just wanted to have a quick reminder. There is going to be an emergency and disaster congress again in Turkey, in Istanbul, in June. It's done with IMAT, and USAM. and a lot of the Balkan states. And I hope to see you in Prague. Now I'm finished.
Okay, well, thank you very much. We do have a minute or two for questions. Do we have any questions for Dr. Leach about this important topic? Okay, well, I don't see anybody raising their hand right now. I'll encourage you, if you had any questions, the speakers may be available after the session is over too for your individual questions. So now it's my pleasure to introduce our second speaker, Dr. Abdo Khoury. Dr. Khoury is a member of the Department of Emergency Medicine and Critical Care at the University of Franche. He's a vice president of the International Pan-Arab Critical Care Medicine Society. He's a member of the research committee at the French Society for Emergency Medicine and also the industry liaison officer at the European Society for Emergency Medicine, and is very active politically in the European Society of Emergency Medicine and in a lot of places in the MENA region. Dr. Khoury's talk this morning is entitled Difficulties in the Field Hospital. So it's my pleasure to introduce Dr. Khoury.
Thank you, Mr. Chairman, for this extensive presentation. Thanks a lot. I'm really happy to be here. I'm really privileged to be here. I want to thank the Professor Bashar Khan Chander for this invitation. I've been here for the past, I think, 5, 6, 7 years, I don't know. I feel like I've been here eternally. And I'll try to speak in this disaster session about difficulties in the field hospital. So for those who don't know me, I'm coming from Besançon, from the eastern part of France, very nice city. I invite you all to my city. This is our trauma center, level 1, 2 helicopters, EMS, dispatch center. We do lots of retrieval. For this talk, I don't have any conflict of interest in any kind of disaster, neither with Mr. Kalashnikov, but lots of acknowledgement for people I work with from different countries, from Turkey, from Belgium, from France, and everywhere. And especially with Maud Michalou from the Summit of Paris, because we work extensively in training in disaster medicine, in training also in dispatch and disaster on the field. As you all know, disaster was defined by the United Nations by a serious disruption of the functioning of the community or a society. And then the impact of this will exceed the ability of the affected community to cope with this disaster and to cope with its own resources. You know the cycle of disasters, and when the sudden onset of disaster occurs, it happens with little warning, and it means that you don't have enough time to get prepared. So it's going to arrive at one night, in one morning, and if you're not prepared for that, you're going to be really, really late on the response. This is how usually it happens before and after. This is a picture from the tsunami, and I think you all remember these pictures. It was before and it was after, with nothing remaining. But it's the same when you have an earthquake, when you have a typhoon, when you have war in Syria or others, when you have flooding. This is what happens. You don't even have hospitals. And the massive number of casualties and the ability of your healthcare system to cope with this will be completely reduced or completely maybe unrealistic and unreal. So it's completely compromised. And this is why when we operate in these kind of situations, we operate derived from the military. We learned a lot from the military, and we started to use field hospitals from the military and from the military doctrine and to cope with these situations. And this is how it looks like, a military field hospital. It's NATO standards. This is a French one, but these are NATO standards. But these NATO standards and these army standards are not really applicable for civilian disasters. And some years ago, in 2003, in San Salvador, there were a big gathering for United Nations, for WHO, and they started to define and try to define the field hospitals and what are the requirements for the field hospitals and what are these field hospitals and how can we implement them and how can we deploy them in disaster countries. So there are lots of roles of these field hospitals, but at least they should provide early emergency medical treatment and also provide follow-up, and sometimes act as temporary facilities or substitute completely damaged healthcare system. So it's quite a huge configuration. Although it was written in like 30 pages at that time, it's come kind a huge configuration and a huge requirement. But the problem is that one day came Haiti. and I think that all of you remember Haiti and remember the extensive damage that Haiti have had, and still these consequences are up to today, 10 years later, we still are coping with these consequences of Haiti, in terms of destruction, in terms of lots of UN and lots of international help and aid. Everyone wanted to go to Haiti. Everyone wanted to be on the picture. Everyone wanted to be represented. And from everywhere, we came to Haiti. 44 foreign field hospitals, more than 18 countries represented. And you see some from Turkey, from France, from Israel, from everywhere. And everyone wanted to be there. And in my opinion, in the opinion of lots of others, it was a complete mess. We really messed up in Haiti. And I think this is why some years later, in 2013, we've gathered the United Nations, and they once again have tried to work on these procedures and work on the deployment of immersive medical teams and foreign medical teams and immersive field hospitals to just try to regulate all this and not have the same picture that we have in Haiti. And Dr. Gianni, who is our next speaker, was extensively involved in this writing of these protocols. So this is how it looks like. It's derived once again from the military, but once again it's applicable much more for civilian. And you see that you have 3 roles or 3 different organizations or 3 different involvement. The first one, to be able to give triage, outpatient care, emergency medical care. Then if you are more important, you can also bring inpatient surgical care. And if you are much more important, you can bring also inpatient care and much longer term patient care and field hospital. And also they specified for some more roles, some specialized team in burns, in pediatrics, in the dialysis, for crash syndromes, and all this. So you see, once again, derived from the military field, but we just applied them for civilians, and we just configured this for civilians. So we trained, and we in France have also our response team, rapid response team, and to go and be deployed within hours outside France also. And we train a lot. We train in establishing our tents. We train in doing our field hospital. We train and see the very nice field hospital upstairs. We train to put all this into configuration and a minimal amount of time. But unfortunately, it's not always what we expect when you arrive on the scene. We have lots of difficulties, and I won't talk about all difficulties that we can encounter. I'm going to talk about some which are important in my point of view. First of all, the configuration of the field. When you arrive somewhere, it's not that nice that we saw when we are training. Sometimes it looks like this. And this is field hospital from the Red Cross in Bangladesh. So you see, all are dispatched in the forest. All X-ray is far from triage far from OR. So it's not the way we trained for that. So it's something challenging for us, and you have to cope with this, and you have to adapt to this. Second difficulty, the security. And I think the security is much more important than other things. You are in conflict zones, you are in war, you have floodings, you have lots of things, and you have also riots, and people want all of them come and gather and have the medical equipment and medical health care and the medical aid. So they are all can be of threat for you, and so you have to discuss your own security and something important. But also evacuation. When you evacuate your wounded or your people, how can you evacuate when the weather is bad? When you don't have place to land your helicopters? When you have lots of crowd that you cannot come and deliver proper aid? So these things are challenging, and the evacuation should be considered and took in place. Otherwise, it can be very, very tough for you to do your mission completely. And when you evacuate, where do you want to evacuate? Is it close? Is it long? This is an example of the French military aircraft. It's ICU aircraft that you can transport around 30 wounded with ICU and with other ICU and non-ICU patients. But you can work a lot on them. You can do ultrasound, you can do a lot of things. It's really ICU airplane. But once again, when you evacuate, you have to know where to evacuate and what is the range of your plane, what is the range of your helicopters to know what the evacuation will be. And then one more difficulty about the length of your mission. You have to think of rotating your teams. When you get deployed somewhere, you're not deployed for 2 days or for 4 days. You have to know for how many times you're going to be deployed. And if it's a longer mission, you have to think about rotating your teams because they'll be exhausted, they won't be operational, and they have to work on that. And the team you're going to deploy the first hours or the first days or the first weeks won't be necessarily the same that you're going to deploy 1 month later or 2 months later. Not the same. So once again, you have to cope with this beforehand, and you have to think of this beforehand. You have to think about your supplies. How do you have supplies to your field hospital? Okay, you have lots of things for the first week, second week, but when the mission will extend for 1, 2, 3, 4 months, how do you have the supplies? With some uncertainty, some security issues, some weather issues maybe. So you have to work on that beforehand. And as I told you, you have to adapt your mission, because at the first days, you are doing the emergency care, but afterwards you are doing the rehabilitation and you are doing regular health issues. And then you can cope with normal diseases, chronic diseases, and shortage of medication, shortage of supplies, and all that stuff that you have to supply for the population. It's something quite tricky, and you have to work on that. And especially you have to have in your teams different profiles. Not only emergency physicians and surgeons and critical care physicians or anesthesiologists. You should have also internal medicine, pediatricians. This because it's gonna start longer, gonna stay longer. So we train, and we were deployed all over the world almost, different configurations with field hospitals, without field hospitals, and we're working on differentiating the crisis typology. As you know, you have short crisis and long crisis, and you have to adapt on this. Every one of this is not the same.
Objective global assessment. This is a structured approach to taking a history that includes weight change, changes in food intake, gastrointestinal symptoms, and functional impairment. And is combined with a physical examination looking for evidence of the loss of subcutaneous fat, especially at the chest and triceps, muscle wasting, especially at temporal region, deltoids and gluteus, and also an examination for edema and acids. To actually measure energy use requires sophisticated equipment, so requirements are more often estimated using formula. One such formula, maybe the most famous one, is the Harris-Benedict equation, which estimates basal metabolic rate in kilocalorie per day. The equation will usually give a result of around 25 kilocalorie per day, 25 kilogram per day, and the equation estimates basal metabolic rate in afebrile healthy individuals and will therefore need to be modified according to the situation to calculate resting energy expenditure. And when prescribing enteral or parenteral nutrition, the appropriate body weight from which to calculate caloric and protein intake, which is called the dosing weight, must first be determined. Guidelines indicate that protein requirements increase as illness becomes more severe. Practices to give patients with only mild to moderate illness 0.8 to 1.2 gram/kilogram protein per day, and critically ill patients are generally prescribed 1.2 to 1.5 gram/kilogram per day, and patients with severe burns, that's the most dramatic one, may benefit from as much as 2 gram/kilogram per day. And also the other essential nutrients, lipids provide 9.3 kilocalories per gram, and calories from lipids should be limited to 40% of total calories. And usually, standard enteral nutrition delivers approximately 50% of calories as carbohydrate and 30% of them from fats. And it is also reasonable to provide vitamins and trace elements to critically ill patients, regardless of the type of the nutritional route. The optimal mixture of vitamins and trace elements is yet to be determined, so daily recommended allowances should not be routinely exceeded in the absence of well-designed and valid randomized trials. So I have talked about a lot of formulas, a lot of numbers. Maybe it's better to make it simple with a case. A case example of 33-year-old male admitted post-laparotomy for a ruptured appendix and sepsis with a body temperature of 39 degrees. How should we calculate the energy requirements of this patient? Let's go with Harris-Benedict formula. First, we should estimate basal metabolic rate, then modify this value according to his clinical situation to calculate resting energy expenditure. The modification for temperature and sepsis are additive, and the caloric requirement works out to approximately 2,500 kilocalories per day. As you see, the basal metabolic rate we find with Harris-Benedict formula is nearly 1,800 kilocalories per day, and we have to add 20% for temperature, 9% for sepsis, and 6% for surgery. Now, how should we give this energy? We provide 40% of this requirement with lipids, and we will provide 1.5 kilogram per day protein, and in the end, the remaining energy comes from carbohydrates, and it seems that 106 grams of lipids, 112 grams of protein, and 234 grams of carbohydrate per day for this patient's requirements. But how should we do? How should we give this energy? We should bolus it from the beginning, or we should start slowly? We should start slowly. An acceptable initial nutritional goal is 8 to 10 kilocalories of calories per kilogram per day, and then 18 to 25 kilocalories and 1.5 grams of protein per kilogram per day after 5 to 7 days. How should we administer it? Nutritional support can be given through oral, enteral, or parenteral routes. And if at all possible, oral or enteral are the preferred routes for nutritional support. They are far cheaper, more physiological, reduce the risk of peptic ulceration, minimize mucosal atrophy, since food in the gut lumen is a potent stimulus for mucosal cell growth and may reduce translocation of bacteria from the intestinal lumen. And the nasogastric tubes is the most common method in ICUs, but it also has some disadvantages, like it can cause malposition, difficulty swallowing or coughing, discomfort, sinusitis, and nasal tissue erosion, but it is still the most common method for nutritional support. Also, oral tubes, enterostomy, and post-pyloric feeding are the other enteral nutritional methods. Parenteral nutrition is most often given via a central vein, as the solutions are usually hypertonic. Preparations for peripheral use are available, however, they have to be isotonic, which means that very large volumes would have to be given to provide adequate nutritional support, and this severely limits their usefulness. And for a successful enteral nutrition, there is much discussion about that, but there are some simple guidelines, some simple points. For example, the first one is, let's confirm the tube position. Because otherwise, the most common complication of enteral nutrition we will face aspiration. So it should be better to confirm the tube's position both clinically and radiographically if it is possible. And also there should always be a high index of suspicion that the tube may have become dislodged, which is an easy thing, and the patient should be set up to an angle of at least 30 degrees to minimize the risk of reflux and subsequent aspiration of gastric contents. This can still occur around a cuffed tracheal tube. And maybe the most important part of my presentation is early feeding. Early feeding has been shown to reduce septic complications, length of hospital stay, and readmission rates in patients after both upper and lower gastrointestinal surgery. And that's true for also the medical patients. Enteral feeding does not appear to increase and may in fact decrease the incidence of anastomotic breakdown. And large volumes of feed in the stomach will increase the risk of aspiration of gastric contents. So bolus feeding should be avoided if possible. Also, if the patient is not tolerating enteral feed, then prokinetic agents, such as IV metoclopramide, should be given. Guidelines discourage early enteral nutrition in critically ill patients who are both hemodynamically unstable and have not had their intravascular volume fully resuscitated, since such patients may be predisposed to bowel ischemia. Hemodynamic instability by itself, unless severe, is not a contraindication for enteral nutrition if there is evidence for adequate volume resuscitation and tissue perfusion. Other contraindications to enteral nutrition include bowel obstruction, severe and protracted ileus, major upper gastrointestinal bleeding, intractable vomiting or diarrhea, severe hemodynamic instability, gastrointestinal ischemia, and a high output fistula. But despite these complications, still the most important route, the preferred route, is enteral route. And the best time is in the first 24 or 48 hours. And for parenteral nutrition, it may be given via peripheral vein if it is significantly more dilute, so-called peripheral parenteral nutrition. Because of the lack of benefit from short-term parenteral nutrition, peripheral parenteral nutrition is rarely indicated. In general, for short-term administration of total parenteral nutrition, peripherally inserted central catheter is the preferred route. Alternatively, but not preferable, total parenteral nutrition may be administered through a subclavian, internal jugular, or femoral central venous catheter if total parenteral nutrition is only needed for very short periods, like a few days, or if a peripherally inserted central catheter is not feasible or reasonable. For long-term administration of TPN, a tunneled central venous catheter is the preferred route. Guidelines use an arbitrary cutoff 30 days to distinguish short-term from long-term total parenteral nutrition use. So, if you are going to provide a parenteral nutrition which lasts less than 30 days, then we should choose peripherally inserted central catheter. If it is more than 30 days, then the best choice is tunneled central venous catheter. We very rarely use peripheral veins, and if the peripherally inserted central catheter is not feasible or not reasonable, then we may use subclavian, internal jugular, or femoral central venous catheters, but that's not the best choice, especially for the femoral central venous catheter. We face a huge risk of infection. And contraindications to parenteral nutrition includes hyperosmolality, severe hyperglycemia, severe electrolyte abnormalities, volume overload, inadequate IV access, and inadequate attempts to feed enterally. Relative contraindications to parenteral nutrition are not well defined. However, parenteral nutrition is often avoided in sepsis, systemic inflammatory response syndrome, gastrointestinal bleeding, short-term mechanical ventilation, and conditions expected to reverse quickly that temporarily preclude enteral feeding. And usually we do not suggest to start parenteral nutrition for the first 5 to 7 days, unless the patient is severely malnourished and it is impossible to use the enteral nutrition. When it comes to complications, maybe the most problematic complication is refeeding syndrome. Patients who are severely malnourished or have undergone a significant period of starvation are at risk of refeeding syndrome during the first few days of nutritional support, regardless of the route. The clinical features include weakness, respiratory failure, cardiac failure, arrhythmias, seizure, and death. Starvation causes a loss of intracellular electrolytes secondary to leakage and reduced transmembrane pumping, and intracellular stores can become severely depleted even though serum levels may be normal. When carbohydrate is available again, there is an insulin-dependent influx of electrolytes into the cells, which can result in rapid and severe drops in serum levels of phosphate, magnesium, potassium, and calcium. And it usually starts with hypophosphatemia. So, Based on this pathophysiology, it's better maybe to start slowly. But how? To the feeding. At-risk patients should be identified and feeding must be introduced slowly, starting with only 25 to 50% of energy requirements and gradually increasing after 4 days. Electrolytes should be generously supplemented at the same time as starting feeding and should be closely monitored. Thiamine and other vitamin Bs should also be given IV before starting feeding and then daily for at least 3 days. As I mentioned before, it's better to start with 8 to 10 kilocalories. Then we also protect our patients from the refeeding syndrome. As you see, it is approximately 40 or 30% of the total energy when we start with 10 kilocalories per day for the first 5 or 7 days. And another complication, overfeeding can cause uremia, hyperglycemia, hyperlipidemia, fatty liver, hypercapnia, especially with excess carbohydrates, and fluid overload. And to avoid from that, it's better to closely monitor the patients. Another important complication, hyperglycemia, is shown that critically ill medical and surgical patients who are hyperglycemic have a higher mortality rate than patients who are normoglycemic. And hyperglycemia can be related to overfeeding, but it is often not. It is not a rare thing that critically ill patients become insulin resistant as part of the stress response. And it is an acceptable approach to have a blood glucose target of 140 to 180 milligram per deciliter in most critically ill adult patients. And there are some other suggestions like targeting 8 to 110 milligram per deciliter, but it is shown that when we target this, we have hypoglycemic attacks, and it is proven that are related to higher mortality rates. And when we choose a more liberate target like 180 to 200, it is also shown with poor prognosis. So it's a simple and a good approach to aiming the 140 to 180 milligram per deciliter. And the most common risk with enteral feeding is aspiration of feeding causing pneumonia. The implementation of a combination of measures as well as a nurse education program and good oral hygiene has been shown to decrease the risk of ventilator-associated pneumonia. Diarrhea can also be a problem, but is not an indication to stop feeds. Other causes of diarrhea need to be excluded, but if enteral feeds are the cause, then a feed with more fiber can be tried. The more common adverse metabolic consequences of enteral nutrition include hyperglycemia, micronutrient deficiencies, and refeeding syndrome, which we mentioned earlier. And the most common mechanical complication of enteral nutrition is constipation. Development of a fiber bezoar is a rare complication that can occur among patients receiving enteral feedings with fiber. And fiber bezoars may be more prevalent when peristalsis is impaired, such as in patients on pressors. So fiber should be used in such patients with caution. Either constipation or a fiber bezoar can cause impaction, bowel distension, perforation, and death if not treated early, although these sequels are very rare. And insertion of a nasogastric or nasoenteric tube can also cause mechanical complications such as insertion into the lung. And the specific complications of parenteral nutrition, the insertion and presence of a central venous catheter has inherent risks, including pneumothorax, hemothorax, arterial or nerve damage, infection, central vein thrombosis, and erosion through the wall of the vein or right atrium. And it's thought that some of the increased risk of sepsis seen in patients receiving parenteral nutrition has actually been the result of overfeeding and uncontrolled hyperglycemia rather than due to parenteral nutrition itself. And nevertheless, infection is a serious risk, and the bags must be sterile and discarded within 24 hours of starting. And sterile precautions must be used when changing bags, and the lumen of the central venous line must not be used to take blood or give drugs or fluids. We should only use the parenteral nutrition rod for giving the nutritional support. And parenteral nutrition also predisposes to hepatobiliary disease, including fatty liver, cholestasis, and acalculous cholestasis, electrolyte imbalances, and micronutrient deficiencies. Thank you for listening.
Thank you, Professor Yit. Are there any questions? All right, thanks for an excellent talk. Oh, we have a question.
Firstly, thank you very much for your excellent presentation. There is our intensive care unit in university. Sometimes we ask some questions to our. When we must start nutritional support in the patients, for example, when admission to the sepsis patients, when we must start nutritional support to the patients in intensive care unit, for example, sepsis patients. When admission to the intensive care unit, or maybe the other time failure of the feeding parameters or failure of the laboratory test, what time?
Actually, that's an excellent question, which has a long answer. It may be the best answer, or maybe it's better to start with. It depends on the patient, but there are some very important points about the answer of this question. First, we have to start as early as possible. There's no doubt about that. So it's better to start in the first 24 or 48 hours. And for the sepsis patients, it's also the same. There are some contraindications, as I mentioned in my presentation, like severe hemodynamic problems. Other than that, or bowel ischemia, ileus, or such that things. But even in these positions, we have to insist to use the enteral feeding. So my answer would be in 95% of the patients, or let's say a huge percent of the patients, it's better to start in 24 or 48 hours with enteral nutrition. For parenteral nutrition, even the patient is in not a good condition, we should wait for 5 or 7 days. If it is going to be a problem about enteral nutrition and we will start enteral nutrition in 3 or 4 days, we can start in 3 or 4 days. Let's say the patient has a subileus, but it seems that in 3 or 4 days we will handle that problem and we will start. Then we should wait for enteral nutrition. In that position, we do not start parenteral nutrition.
Thank you very much.
It's my pleasure. Thank you.
Dear participant, now the second speaker, in my opinion, he is pioneers of emergency medicine and international advocate of EM and past president of USM. I invite Abdullah Bello. Your topic, patient safety reporting system in the emergency. Stage is yours.
Thank you very much, Chairman, and I'm happy to be here. First, I would like to thank again Bashar Kandar and Beset all and all the team, because it's a teamwork for this fantastic Congress. The first slide, can you, the only thing is important in the slide is my email. Please take my email. We are a project for the next Congresses to implement a global international course in quality and safety. And I do believe that this topic is one of the most important in medicine, and particularly in emergency medicine. I'm a basic researcher. I'm doing research in rat and mouse. This is my patient. And my second patient is quality and safety. I have two dreams. The first one is I don't want to be rich. I want to be happy. My second dream is I want to give to patients I'm managing in the emergency department the best care I can give to them. I want to share with you some concept and philosophy, and I will bring some data about reporting system in emergency medicine. I have no conflict of interest, and yesterday I showed you this slide. Please do something. And if you do good and this something work, do it more. If it doesn't work, stop it. Now the message is do something. I want also to share a story from Amerindian people, and this is a very nice story. One day, a big fire started in the forest. Big fire. And all the animals were completely in panic. And this lion, or the big animals, they were watching this very small bird, the colibri. And the colibri was going forward and forward, bringing water, small water, and put the water in the fire. The lion said, "Why are you doing that, small bird? Do you think that you are going to stop the fire in the forest?" And the small bird said, "Okay, I'm small, but I'm doing my job. I'm doing my part of the work." This is the message for quality and safety. We have all to do our job, our part of the work, and we have to be excellent in what we are doing. The concept of quality started many centuries ago, and I'd like to show you this slide, and particularly this Aristoteles is a very important Greek philosopher. He said that quality is not an act, quality is a habit. Yes, it must be a habit. Every day you have to be the best, and the next day when you look yourself at the mirror, you have to say, "I will be better than yesterday. I will manage the patient better than yesterday." And also Hippocrates, and Hippocrates said, the most important is not the disease, the most important is the patient. Keep in your mind. And I think we forgot this concept of patient in the center of the healthcare, and let's say now in the healthcare system. Yesterday I showed this slide. Our objective is to balance between the performance, the excellence, and the requirement. It's important to have requirements, to have standards, to have guidelines, and we are working on that for many years. For the next century, I think, the objective is to have global guidelines for everybody in the world. Quality and safety is a matter of support from government because it needs a lot of money, and you will see some figures, and it needs a lot of agency, institution, organization working together to get data which will be helpful to improve the quality of the care. You know very well, I showed you the slide yesterday, keep it in your mind. Healthcare system is killing more than aviation. Every year in America, for example, but I think we have the same figures all over the world, 120,000 patients die because of adverse events and medical errors. Put this in your mind. That means we have a lot to do to improve our quality of care. This is very expensive, very costly. You can see here that the cost in America, we have a lot of data from America, the cost for adverse events is up to 50 billion, which is huge. That means we always say that quality is expensive because we have to put a lot of money to organize better our healthcare system. But non-quality is more expensive than quality. Keep in mind this slide, and you have to go to read this report. The journey of quality and safety started in 1999 with this report. This is a very important report from the Institute of Medicine in America. And this report has this title, "To Err is Human." To err is human. We have to stop to blame people. We have to understand why we do errors. Once we do that, we decrease the number of errors, and we decrease also, of course, the adverse event. Very important. To err is human. We have to implement a culture of safety, a just culture of safety. This is very important. I like this slide. I built this slide to show you